Good afternoon, all. Hope everyone came back after your lunch and hope you had a good lunch in your respective home. And now we are going to start with a topic that is going to be your diuretics, cardiovascular system. And we will move towards the third important drug that is going to be your GAT. So these are the three things which we are left with. Already ANS is covered in my YouTube channel, so you can go and watch that ANS topic, and general pharmacology is also already covered. So only these three are left. So its time is 2:30. So we will be maximum completing it around 5 o'clock. So 2:30, 3:30, 4:30 and 5, 2.5 hours left with us. So it's a very, very short topic. So we are going to cover these three drugs. Okay, these three drugs. Before the lunch session, so we had actually discussed about the gout. Okay, we have discussed about the DMARD. In that one point I have left to tell you, that is going to be the drugs that are causing gout. So remember, like with this mnemonic, PAINED, pained. So we are going to remember with this mnemonic, pained. So P stands for pyrazimide, A stands for aspirin, and I stands for immunosuppressant. I stands for immunosuppressant, and your N stands for niacin, E stands for ethambutol, and D stands for diazide. These drugs are the one that can cause gout. So that is, they are going to lead to increase in the uric acid in the body, so that can precipitate gout, so yesterday we were discussing about the immunosuppressant cyclosporin tacrolimus. That time also I was telling you, and your pyranzapine, when we are discussing anti-TB drugs, that time also I was telling you that they are uric acid increases, so they will be increasing the uric acid level in the body. Okay, now this one, tocilizumab. This was actually a previous year question. Tocilizumab is a one interleukin 6, that is going to interleukin 6 inhibitor, that is going to act against the rheumatoid arthritis, as well as it is going to cause a cytokine storm. It is going to be given in the cytokine storm in the COVID-19. This was I also discussed this in the previous before the lunch. So this you can just remember like this: methotrexate, sulfasalazine, chloroquine, hydroxychloroquine, leflunomide, and penicillamine, and your gold. These are the DMARDs, disease modifying rheumatoid arthritis. Okay, disease modifying. Okay, your rheumatoid arthritis drugs. Okay, wow. So now we are moving towards this. All we discussed already. So just take a screenshot of this page also. See, infliximab is the only IV drug which we give. Apart from that, we have certolizumab, adalimumab, golimumab, and eticept. So this is all going to be your anti-TNF alpha. Anti-interleukin 6 is going to be your tocilizumab and sarlizumab, and your anti-CD20 rituximab, anti-interleukin 1, that is anakinra. Then we have REC or CTLA4, that is going to be abatacept, and JAK kinase inhibitor, all your tyrosine kinase inhibitor like your tofacitinib, baricitinib, and upadacitinib. Okay, okay, with this completing all the important points. Now we are going to move towards a very important topic, that is going to be your diuretics. Are you all ready to discuss about diuretics? Okay, so I'll just give you a brief introduction about the diuretics. Kindly understand. So we just understand with this image. So what happens is, you have something called as glomerulus. So just focus only on this image. Okay, just focus only on this image. You have something called as, you have something called as glomerulus. This glomerulus is where all your blood is going to get filtrated. So once there is going to be filtration, what happens? You're going to have a filtrate. That filtrate is going to enter into the proximal convoluted tubule. That filtrate is going to enter into the proximal convoluted tubule. Once it is going to enter into the proximal convoluted tubule, you have 80% of all the components of your blood, all the components of your filtrate that is going to be present in the glomerular filtrate are going to be reabsorbed. What are the substances that are going to get reabsorbed? There is going to be reabsorption of sodium, there is going to be reabsorption of your water, there is going to be reabsorption of amino acid, there is going to be reabsorption of hydrogen ions. There are everything that are going to be reabsorbed here. So this is your proximal convoluted tubule. So for the proximal convoluted tubule to have a proper function, what is one you need? You need carbonic anhydrase. So you need carbonic anhydrase. For the proximal convoluted tubule to function, you need something called as carbonic anhydrase. Now coming to the After the proximal convoluted tubule, slowly it is going to move as a loop of Henle. In the ascending limb of loop of Henle, you are going to have sodium potassium ATPase, sodium potassium 2 chloride. So you are going to have sodium potassium 2 chloride. This sodium potassium 2 chloride, remember, they are going to be a symporter. Sodium potassium 2 chloride is a symporter that is present in the ascending limb of loop of Henle. In which ascending limb, whether it's thick or thin, if you ask me, it is your thick ascending loop of Henle. Thick ascending loop of Henle. Now, here you're going to have 25% absorption of your sodium. Remember, in your proximal convoluted tubule, you have around 65% of sodium absorption. And in your thick ascending limb, you are going to have 25% of sodium getting absorbed. So around 65 plus 25 and 75, 85, 90% of sodium is absorbed at the ascending limb of loop of Henle. Then the remaining 5%, it is going to be absorbed here in your distal collecting tubule or your distal convoluted tubule. In your distal convoluted tubule, you're going to have a sodium chloride channel which is going to absorb the remaining 5%. So already 65% is absorbed in your proximal convoluted tubule, 25% is absorbed in your in your thick ascending limb of loop of Henle. So 65 plus 25, you're going to have already 90%. 5% is absorbed in your the distal collecting tubule or distal convoluted tubule, and then the remaining is going to be absorbed by your collecting duct. In collecting duct, what happens? You have something called as ENaC channel. This ENaC channel, what it does is, it is going to take the sodium, it is going to reabsorb sodium, and it is going to give inside potassium and hydrogen. So sodium is reabsorbed and potassium hydrogen is going to be excreted. Potassium hydrogen is going to be excreted into the urine. Okay, this is going to be your the remaining 1 to 2% is absorbed here. Okay, finally you're going to have water absorption taking place at the collecting tubule, which is present in the medulla. So you're going to have cortex medulla differentiation. So you have to remember this. So your nephron is present in the cortex as well as your medulla. So cortex la da proximal convoluted tubule, the distal convoluted tubule and collecting tubule ellame irukku. And the collecting tubule and the collect agra duct, it is present in the medulla. Okay, now you are going to understand how you are going to your diuretics acts. So what is the main role of diuretics? The diuretics are given to block your water excretion. Okay, why the diuretics given? Can you tell me why diuretics given? When you will give diuretics, can someone tell me why is a diuretics given? In which conditions diuretics is given? When there is going to be a volume overload. When there is going to be volume overload in the body, you will be going for the diuretics. So that what is the meaning? Diuretics is going to increase the water excretion in your urine. So in order to increase the water excretion in the urine, so always remember water and your sodium are always like a thick friends. If water is going out, sodium is also going out. Like how you and your friend will be there when the faculty was seeing you guys are talking, then what she will tell? She will send one outside. Then what you will do? You will also go out along with them and you will enjoy. So likewise, what happens? The sodium and your water are like very thick friends. They will be always together. Okay, so இங்க என்ன ஆகுதுன்னா, so first point what you're going to remember is whenever sodium is going to get out, water is also going to get out. That is the first point which you are going to remember. Second point, whenever sodium is getting out, whenever water is getting out, except your collecting tubule, even your potassium will be getting out. That means that when you're going to block your proximal convoluted tubule, when you're going to block your loop diuretic, when you're going to block your thick ascending loop of Henle, எந்த இடத்தை நீங்க block பண்ணாலும், okay, you're going to have the inhibition of, okay, sodium is not absorbed, water is not absorbed. Along with it, potassium will also get not absorbed except one place. What is that? In your collecting tubule. Because your collecting tubule is going to be a symporter where sodium is going to be absorbed, in turn potassium and water is going to be excreted. So when you're going to block that area, we are going to block that symporter. Okay, when you're going to block that transporter, what happens? Sodium absorption நம்ம prevent பண்ணும். அதுதான் நம்ம aim. Diuretics ஓட aim என்ன? Water, sodium, reabsorb agama, we are preventing. Appa, when you are going to prevent it from reabsorption, in that case, what happens? Potassium is not excreted into the urine. potassium and your hydrogen ion is not excreted in the urine. Can you see here? Okay, can you see this place? So sodium, if you are not going to let it absorb, sodium, when you're going to not let it absorb, your potassium and hydrogen will not be excreted. Your potassium and hydrogen will not be excreted. So now what happens is we are going to see one by one. When this area is blocked, so how you can block this proximal convoluted tubule? By giving carbonic anhydrase inhibitor. When you are going to give a carbonic anhydrase inhibitor, what happens? There is no carbonic anhydrase enzyme. Because of that, the proximal convoluted tubule will not be functioning. When there is no functioning of your proximal convoluted tubule, what happens? There is an increased excretion of sodium and absorption nadakala. Sodium, water, potassium இதெல்லாமே அப்சர்வ் ஆகல. அப்ப sodium, potassium, bicarbonate, water இதெல்லாமே it is going to get excreted in the urine. Now tell me, whenever more sodium gets excreted in the urine, what will happen? Can you just put in the chat box? When sodium is going to be, more sodium is going to be excreted in your urine, what happens? When more sodium gets excreted in the urine, what happens? What is the first, what is that called as? There is a more loss of sodium. Loss of sodium is called as what? The name given for loss of sodium. Can you tell in the chat box, anyone? Arfif, Ajay, Dinesh, Siva, Sanjeev. Can you put in the chat box? Loss of sodium in urine is called as hyponatremia. It is in the blood. When there is excessive amount of sodium in the urine, it is called as hypernatriuria. So you have hyponatremia and you're going to have hypernatriuria. Excellent. Now second one, whenever there is going to be more amount of potassium excreted in the urine, what happens in the blood? What is going to be the end result in the blood? What is going to be the end result in the blood? Can you tell me? What happens to the metabolic changes? You're going to have a less amount of potassium in your blood. When there is a less amount of potassium in the blood, what do you call it as? Hypokalemia. Excellent. So hypernatriuria, hyponatremia, hypokalemia. Fourth one, you're going to have loss of bicarbonates. When excessive bicarbonate is lost in the urine, there is a reduction in the bicarbonate amount in the blood. When you know that bicarbonate is a basic. So when the base is reduced, what happens? There is nothing to neutralize your acid. Therefore, you will have a metabolic acidosis. Now, can you remember, whenever you're going to give a carbonic anhydrase inhibitor, when you're going to give a drug called as carbonic anhydrase inhibitor, what happens? There is going to be a metabolic acidosis, hypokalemia, hyponatremia, hypernatriuria. Apart from that, you have one more thing. Remember, in your proximal convoluted tubule, you have this calcium. Okay, proximal convoluted tubule, calcium is going to be excreted. Okay, calcium has to get reabsorbed in your proximal convoluted tubule. Now, what happens here? Your proximal convoluted tubule is not going to perform the action that has to perform. Because of that, what happens? There is excessive amount of calcium excreted in the urine. Now, when the excessive amount of calcium excreted in the urine, what happens? It can lead to calciuria, hypercalciuria, number one. Number two, they can form calcium stones. So they can form a calcium stones all along your uro pathway, in the urinary pathway, and that can lead to urolithiasis or your kidney stones. We call it as nephrolithiasis, urolithiasis. All this will be occurring. So what is the side effect of your carbonic anhydrase inhibitor? If they are going to ask you, the side effects of carbonic anhydrase inhibitor are, number one, metabolic acidosis, hypercalciuria, hypokalemia, then there is going to be a renal stones. These are going to be the side effects of using a carbonic anhydrase inhibitor. What is the example of carbonic anhydrase inhibitor? Hypercalciuria. Hypercalciuria. Exactly. There is going to be hypercalciuria and there is going to okay, see, your calcium is also absorbed in your proximal convoluted tubule. Calcium is absorbed in your proximal convoluted tubule. When this calcium absorption is not occurring in your proximal convoluted tubule, more amount of calcium is excreted in the urine. When more amount of calcium excreted in the urine, you call it as hypercalciuria. First point. Second point, when more amount of calcium is going to be excreted in the urine, they may cause deposition leading to renal stones, nephrolithiasis, urolithiasis. Clear, right? Yes. Now, these are going to be the carbonic anhydrase inhibitor or a side effect. Now, the question is, what is carbonic anhydrase inhibitor? What is the drug that you are using? Just write it down. Just copy this image. You're going to copy only one slide. You're going to see before the exam. Only if you're going to see this slide, you will be able to understand everything regarding your all your diuretics. Now see, carbonic anhydrase inhibitor. What happens? What are the example of carbonic anhydrase inhibitor? It is going to be acetazolamide. Acetazolamide is a non-competitive and reversible inhibitor. It's a non-competitive and reversible inhibitor of your carbonic anhydrase enzyme. Clear, right? Now, what is the action of it? So it has different action. It is not going to act only in your kidney. It is going to have different actions, which we will be definitely seeing in the theory. Now, for now, you remember this alone. I'll be explaining you about each and every drug later. For now, just remember acetazolamide is going to be the drug which is going to be present in your carbonic anhydrase inhibitor. Next, let's come to the Next, let's go to the thick ascending loop of ND. Now we are going to move towards the thick ascending loop of ND. What is the receptor? What is the receptor or transporter you have here? It is sodium potassium 2-chloride symporter. Every time what we usually think is for sodium, when it is going to enter out, potassium exits. This is the mindset we have because sodium potassium ATPase functions like that. But here it is going to be sodium potassium 2-chloride symporter. That means that sodium, potassium, chloride, everything is going to get absorbed in your thick ascending loop of ND. Clear, right? In thick ascending loop of ND, sodium, potassium, 2-chloride, everything is going to be absorbed inside. So when you're going to give a drug that is going to prevent the absorption by your sodium, potassium 2-chloride, what happens? You are going to block the sodium absorption, potassium absorption, chloride absorption. Okay, along with so along with it, remember you will also have calcium absorption at this thick ascending limb of loop of ND. Calcium will also get absorbed and magnesium is also getting absorbed. So add up another point. Magnesium is also going to get absorbed. Now, when you're going to inhibit this absorption, what happens? Again, there is going to be a hyponatremia, hypernatriuria, hypercalciuria. There is going to be a hypokalemia, hyponatremia. But remember, here you are not inhibiting the NaHCO3. That is going to be your bicarbonate absorption. Like எந்த ப்ராப்ளமும் இல்லை. Bicarbonate has got absorbed. So here you will not get the metabolic acidosis. But ultava, what happens is there is going to be inhibition of your chloride. You know that the main acid which is present in our body is going to be your HCl, isn't it? The main body that is going to be present in our body is HCl. So adula chloride illa. Appa acid production stop agudhu. This is point number 1 you should note. Okay, this is a point number 1 you're going to note. And second thing what happens is here you're going to have a sodium absorption problem. Whenever there is going to be a sodium absorption problem, what happens? The next important which is going to be there is going to be your this one. That is going to be your sodium potassium hydrogen transporter. Sodium is going to get absorbed and potassium hydrogen is going to be secreted in the urine. So now what happens is, now since sodium is not absorbed in your thick ascending limb of loop of ND, in here sodium is not absorbed. Since sodium is not absorbed here, what happens? There is going to be an increased absorption of sodium in your collecting tubule. In collecting tubule, there is an increased absorption of sodium. When there is an increased absorption of sodium in the collecting tubule, think what happens? There is going to be more amount of potassium and hydrogen getting excreted in the urine. Already you know potassium is excreting even in your thick ascending limb of loop of ND. Apart from it, there is more amount of potassium that is excreted in the urine. Now you have a severe hypokalemia. Remember, you are going to have a severe hypokalemia, number 1. And number 2, H plus ions are going to be excreted in the urine. Because H plus is going to get excreted in the urine, what you will have? You have metabolic alkalosis. Now can you tell me what are the side effects of loop diuretics? Loop diuretics are the one that is going to act, that is going to inhibit your sodium potassium 2-chloride symporter. What is going to be the net effect? Number 1, you are going to have a hypokalemia, you are going to have your hyponatremia, you are going to have hypokalemia, severe hypokalemia. Number 3, you are going to have your hypernatriuria. Number 4, you are going to have your hypercalciuria. calcemia, you're going to have your hypercalcemia. And what is number 5? Remember, the number 5 which we are going to have here is going to be hypomagnesemia. You're going to have hypocalcemia, hypercalciuria, and you're going to have metabolic alkalosis. I explained why there is a metabolic alkalosis. Is clear, right? Why there is a metabolic alkalosis? I explained you why there is a metabolic alkalosis. That's all. This comes to the end of your loop diuretic discussion. Then you're going to have your NaCl. This NaCl, okay, this is going to be, okay, but we're going to get inhibited. So you're going to have your sodium chloride channel. This sodium chloride channel is going to be inhibited by thiazide diuretics. So you're going to have your sodium chloride. This sodium chloride is going to be inhibited by the group of drug called as thiazide diuretic. So you're going to be inhibited by a group of drug called as thiazide diuretics. Remember, thiazide diuretics is also called as thiazide diuretics is also called as, write it down, moderate efficacy, okay, or moderate ceiling. So we call it as moderate efficacy, or we call it as moderate ceiling. Okay, this one we call loop diuretics, we call it as eye sealing diuretics. We call it as eye sealing diuretics. This is called as moderate sealing diuretics. This is called as eye sealing diuretics. Are you all clear with these two? What is moderate sealing diuretics? What is eye sealing diuretics? Hope you are clear with that. So what are the thiazide diuretics? So first we have to know the example of thiazide diuretics. Remember, so what is the example of your loop diuretics? Write it down. The examples of your loop diuretics are furosemide. Example of loop diuretics are furosemide. Okay, you're going to have furosemide, you're going to have a torsemide, you're going to have your butinamide. So what is that drug which is commonly available? Furosemide. If you're going to go to a casualty or ICU in your medical college, if you're going to just see the cash cut, so you're going to have a crash cut. So if you're going to see, you're going to have Lasix, or பெரிய வயல்ல Lasix அப்படின்னு ஒரு drug இருக்கும். That is nothing but your furosemide. So Lasix are nothing but furosemide. Your Lasix are nothing but furosemide. Now coming to the thiazide diuretics. So now coming to the thiazide diuretic. What are the examples of thiazide diuretics? Anyone? Anyone, do you know what are the example of your thiazide diuretic? Hydrochlorothiazide. You're going to have hydrochlorothiazide. You're going to have your chlorthalidone. Two drugs which is used more commonly in your thiazide diuretics. What are the examples of your thiazide diuretics? Write it down. Number 1, hydrochlorothiazide. Number 2, you're going to have your chlorthalidone. So these two are going to act in the distal convoluted tubule present in the cortex, whereas eye sealing diuretics acts in the where? In your medulla. So thick ascending limb of loop of Andley present in your medulla. Clear, right? So this is a difference between your eye sealing diuretics and moderate sealing diuretics. Second one, if there is an inhibition in your moderate sealing diuretic, you go, what are the symptoms you're going to have? Now again, sodium is going to be excreted. So this causes increased excretion of sodium and chloride, increased excretion of potassium and magnesium. Okay, so there's an increased excretion of sodium and chloride. It is going to have an increased excretion of what? It is going to also have increased excretion of potassium and your magnesium. Adume, even thiazide diuretic, there is going to be increased excretion. But only difference which you are going to have between your eye sealing diuretics and your moderate sealing diuretics is, in eye sealing diuretics, you are going to have a calcium excretion. Okay, you're going to have a calcium excretion. So you're going to have a hypercalcemia. You're going to have a hypercalciuria. So you're going to have a hypercalciuria when you're going to give a eye sealing diuretics or loop diuretics. But what happens in the case of your moderate sealing diuretics? There is no calcium excretion. So calcium excretion irukadu. Now, calcium excretion illana, what happens? So calcium excretion irukadu, uric acid excretion irukadu. So just add one more point. Your loop diuretics will also block the reabsorption of uric acid. Your loop diuretics will also block the reabsorption of uric acid. Therefore, you will also have one more point. What is that? Hyperuricemia. So more amount of uric acid is going to come in the urine. So hyperuricemia. Now coming back to your NaCl, that is thiazide diuretic, which is blocking your NaCl at the distal convoluted tubule. There is no calcium or there is no involvement of your uric acid transporters. Therefore, calcium is not going to get inhibited. So அப்ப என்ன ஆகும்? Whenever there is a increased reabsorption of calcium in the urine. So இங்கெல்லாம் calcium reabsorb ஆகல, வெறும் இந்த பார்ட்ல மட்டும்தான், அதாவது distal convoluted tubuleல மட்டும்தான் calcium reabsorption ஆகுது. அப்ப excessive amount of calcium ஒருவேளை reabsorb ஆச்சுன்னா that is going to lead to hypercalcemia, and this can lead to hypercalcemia will be there. So in which condition you can use? When there is a hypercalciuria or renal stone வந்த patient, அதாவது loop diureticsல இருக்கு பாத்தீங்களா, அந்த மாதிரி ஒரு கண்டிஷன்ல when the patient is going to have hypercalciuria having a renal stone, what drug you can give? You can give thiazide diuretics. Thiazide diuretics causes increased calcium reabsorption. When their calcium is going to get reabsorbed, what happens? It is going to decrease the urine calcium levels. It is going to decrease the urine calcium levels. Thus, it can help in from the calcium stone formation in the urinary tract. Calcium stone formation in the urinary tract. Now coming to the last one, that is going to be a ENaC channel inhibitor. So you have something called as ENaC channel which is present here. Okay, you have something called as ENaC channel that is present here. One, we discussed about the sodium, potassium, hydrogen that is present in the collecting duct. But அது வந்து ஒன்று. இன்னொரு பக்கம் வந்து பாத்தீங்கன்னா you have something called as ENaC channel which is going to be controlled by your aldosterone. You have something called as ENaC channel that is present in the aldosterone. I'll explain you, wait. So just have it, just take this page. I'm just drawing. See, you are going to have, this is going to be your distal convoluted tubule. Just remember, this is going to be your distal convoluted tubule. In the distal convoluted tubule, okay, what happens? You are going, this is going to be your distal convoluted tubule. Okay, this is going to be a distal convoluted tubule, and here you are going to have something called as blood vessel. Here you are going to have vasa recta, where you are going to absorption is going to take place. Okay, this is going to be your, okay, so what happens is you are going to have a sodium potassium ATP, sodium potassium hydrogen transporter, which is going to be present like this. It is going to be present like this, sodium potassium hydrogen transporter. But you have one more thing called as aldosterone receptor. This aldosterone receptor is going to be present in the, okay, outer aspect of your okay, your tube, that is going to be your collecting tube. So collecting tube outer aspect la you are going to have something called as aldosterone receptor. In the aldosterone receptor enna pannuna, they are a mineralocorticoid. You know what is the role of mineralocorticoid? Can you tell me what is the role of mineralocorticoid? What is the role of aldosterone? General physiology question. What is the role of aldosterone? Generally, what is the role of aldosterone? What is the role of aldosterone? Anyone? Anyone? Can you tell in the chat box? What is the role of aldosterone? Aldosterone is going to be a steroid hormone synthesized in your zona glomerulosa. Okay, so which is responsible for fluid balance in the body. So what is going to be the action, main action? What does your aldosterone does? What does your aldosterone does, anyone? It promotes the renal excretion of water. So it is going to be promote your, it is going to promote the renal excretion of sodium, potassium, and your retention of your sodium and water. So it is going to cause, okay, two things it is going to do. One, sodium and water is retained, and other potassium and H2 is going to be sent out. So this is the work of aldosterone. Now you have something called as ENaC channel. If in the ENaC channel block pandra and the drugs we call it as potassium sparing diuretics. Okay, the drugs that are going to inhibit your ENaC channel, the drugs that are going to inhibit your ENaC channel, you are going to call it as another potassium sparing diuretics. Clear, right? That is called as potassium sparing diuretics. So what are the drugs that are going to be called as potassium sparing diuretics? The potassium sparing diuretics are the one that acts on your ENaC is also going to be called as potassium sparing diuretics. The one that acts on the sodium, potassium, hydrogen is also called as your potassium sparing diuretics. The one that acts on the ENaC channel are amiloride and triamterene. So amiloride and triamterene is going to be the ENaC channel inhibitor. We have something called as aldosterone inhibitor. The aldosterone inhibitors are nothing but your spironolactone. So I have told you, we have to learn, right? Spironolactone. They are going to be aldosterone inhibitor. Okay, so inge vandu ungalku block panna enna problem varum? Sodium is not going to be reabsorbed. So the patient will be having what? The patient will be having a hyponatremia. on hypernatriuria will be there. But apart from that, what are the other problem? Your H plus ion is not excreted. Since the H plus ion is not excreted, the patient will have hyperacidosis. So there is going to be a metabolic acidosis. So potassium is also not excreted. Therefore, the patient will have hyperkalemia. So what are the side effects? Hyperkalemia, metabolic acidosis. And you also have to remember that this aldosterone receptor will also have receptors which is going to be block, which is going to block your estrogen and progesterone receptors. This aldosterone which is going to be there, it is going to, this aldosterone antagonist like your spironolactone, they are going to go and block your estrogen and your progesterone receptor. When that is going to block, what happens? The patient will have a libido, decreased libido will be present. The patient will have decreased libido will be present. When the estrogen receptors are blocked, what happens? Excessive estrogen is going to be formed by reverse feedback mechanism. Therefore, the patient will have gynecomastia. So, hope so you all understood this. Take a screenshot of this. I'll give you 5 seconds. Take a screenshot. Now, what I'm going to do, I'm going to explain each and every drug in detail. So next what I'm going to do is I'm going to explain each and every drug in detail. Once you take a screenshot, can you put a thumbs up in the chat box so that I can move towards the discussing individual drug in detail? Let's see the individual drug in detail. Can you put a can you put a thumbs up in the chat box? Can you put a thumbs up in the chat box? Others? Only Ajay is there. Others? Afif, Dinesh, Shiva Sanjeev, Shivaranjini. Okay, thank you. Dinesh, thank you. Okay, now we are going to move into discussion of your diuretics. Okay, so we are going to discuss individual diuretics. Let's discuss the individual diuretics in detail. Just hold on. See here. So we have something called as high ceiling diuretic and your moderate ceiling diuretic. What are the examples of high ceiling diuretic? Furosemide, torsemide, bumetamide. So the three drugs are going to be furosemide, torsemide, and you're going to have your bumetanide. And what are the examples of your moderate ceiling? That is going to be your hydrochlorothiazide and chlorthalidone. Remember, chlorthalidone are long-acting drugs. Put a tableau column like this. Number one, first point is going to be what is going to be the site of action. Site of action is going to be your furosemide is going to be acting in the thick ascending limb of loop of Henle, which is present in the medulla. Whereas moderate ceiling, that is going to be present in the cortex, distal convoluted tubule. Now coming to the mechanism of action. Sodium potassium 2 chloride inhibitor. This is a symporter. Remember, this is a symporter. And your sodium chloride symporter. There is going to be a inhibition of sodium chloride symporter. Okay, now coming to the glomerular filtration rate. See here, GFR. எதெல்லாம் GFR increase பண்ணும்? Your prostaglandin synthesis. I told you already in NSAID, whenever there is a prostaglandin, that is going to increase the GFR synthesis. Correct? So whenever there is a GFR synthesis, okay, so whenever there is going to be a increased GFR synthesis. So what is the diuretic of choice? What is the diuretic of choice? Your diuretic of choice is going to be your AR. In diuretic of choice in your acute renal failure, it is going to be your furosemide. Why I am giving furosemide? Because furosemide will be causing increase in the prostaglandin synthesis. Okay, furosemide causes increase in the prostaglandin synthesis. Ultimately, it is going to cause increase in your glomerular filtration rate. So, in a patient with acute renal failure, what is going to be your drug of choice? So, any drug, whichever you are giving, it should increase the glomerular filtration rate. It should not decrease the glomerular filtration rate. Therefore, the drug of choice is going to be what? The drug of choice is going to be your furosemide. Remember, this increase in prostaglandin will also cause decrease the renal blood flow by vasodilatation. So what you are going to give? You are going to increase the frequency of drug and you are going to decrease the dietary sodium intake. So whenever the patient is going to take a furosemide, you are going to increase the frequency of drug and decrease the delivery of sodium intake. Now coming to the avoided, in which patients you are going to avoid, short T-off is there. So sodium is reabsorbed post-diuretic urinary retention. So sodium is reabsorbed. So the patient may have, what is the side effect? You are going to have post-diuretic urinary retention. Okay, you should be avoiding this. Now coming back towards the common cause, okay, this is going to be your distal convoluted tubule, sodium chloride symporter. This will reduce the GFR. So what you have to do is, if a patient is coming to you with acute renal failure, already the GFR in the patient is reduced. If you are going to give chlorthalidone further, for further the GFR reduces. Therefore, if the GFR is less than 30 ml per minute, you should never ever give chlorthalidone. You should always go for furosemide. Is it clear? Now, what are the common features you're going to have? Hyponatremia, hypokalemia, metabolic alkalosis, hyperglycemia. Why hyperglycemia? In proximal convoluted tubule, there is going to be this SGLT2 receptor. Okay, SGLT2 receptor. This is also going to be inhibited. When you are going to inhibit this, what happens? There is going to be what happens. So you're going to have proximal convoluted tubule and you're going to have loop of Henle. So everywhere what happens, you're going to have your SGLT2. This SGLT2 will be causing what? They will be working fine. So what happens is they are going to lead to hyperglycemia. Is it clear why there is hyperglycemia? So you're going to avoid in diabetic mellitus. You should avoid this in diabetic mellitus. Following by it, okay, hyperlipidemia can occur and hyperuricemia can occur. Hyperuricemia, why? Because there is going to be a increase in the uric acid secretion. That is going to lead to hyperuricemia. Clear, right? Now we are going to move towards what are the difference. Okay, so number one, ototoxicity. Remember, furosemide is your eye sealing diuretic. They are going to be extremely ototoxic in nature because they are going to secrete ithacrinic acid. This ithacrinic acid is going to cause ototoxicity. This is all about your furosemide. You have to remember. And coming to your moderate sealing, that is hydrochlorothiazide or chlorthalidone, they are going to be not ototoxic in nature. Second one, remember, the chlorthalidone is going to cause erectile dysfunction, whereas your furosemide does not cause erectile dysfunction. Third one, this I already told you. Your when you're going to inhibit your sodium chloride channel in your hydrochlorothiazide or chlorthalidone, there is no involvement of your calcium reabsorption. Therefore, calcium is nicely excreted out. So this technique is used in case of hypercalciuria. Whereas in your when you're going to give thiazide diuretic, that is when you're going to give your eye sealing diuretics like your furosemide, dorsimide, butimitamide. So in this condition, what happens? There is an increased calcium loss in the urine that leads to hypercalcemia. There is going to be a hypercalciuria. So there is going to be a hypercalciuria and hypocalcemia. So in a patient with a increased calcium level, hypercalcemic or patient present பண்றாங்க when they are going to come to your OPD, then what you are going to do? You are going to give IV saline to the patient along with furosemide. Furosemide will reduce the calcium level in the body. Thus, it reduces the calcium level in the body. It leads to hypocalcemia. Very important point. Where all you are going to use. Now we are going to see. You are going to use all these, both eye sealing diuretic or your moderate sealing diuretic in edema. You are going to use. In edema, what is the drug of choice? If you ask me, that is your furosemide. So any type of edema, let it be pitting edema, non-pitting edema, what is going to be a drug of choice? The drug of choice is going to be your furosemide. Furosemide is a drug of choice. In acute pulmonary edema, again it's going to be again a edema, right? So the drug of choice is IV furosemide. Okay. In hypercalcemia, when there's hypercalcemia, what is the drug of choice? I told you just now, IV saline with furosemide. And when the patient comes to you with hypertension, the best diuretic is going to be thiazide than your furosemide. Remember, thiazide diuretic is going to be more than your furosemide. Why? Because first point is they are going to be having a long action. So I told you, right, chlorthalidone. So chlorthalidone is a moderate sealing thiazide group of diuretics. They have a longer duration of action. That is why we are used. They have a sustained fall. Number two, chronic use la they are going to be causing a vasodilatation and increased flexibility. And there is no postural hypotension in using your moderate sealing diuretics. Whereas when you use a furosemide, torsimide, bumetanide, they are going to cause postural hypotension. Okay, now patient comes to you with a BP of 220/110. Whenever you're going to have any blood pressure more than 220/110, you're going to call it as a hypertensive crisis. So in hypertensive crisis, what happens? There is a vasoconstriction. Therefore, glomerular filtration rate also will be decreased. I told you that whenever there is going to be a decrease in the glomerular filtration rate, what is going to be the drug of choice? Can you tell me? Whenever there's a decrease in the glomerular filtration rate, what is going to be a drug of choice? Whether it is going to be a furosemide or whether it's going to be a thiazide. Can you tell me in the chat box whether you go for furosemide or whether you go for thiazide group of diuretics? You go for thiazide group of diuretics. Why do you go thiazide group of diuretics? Because, okay, why do you go for thiazide group of diuretics? Why do you go for thiazide group of diuretic, Dinesh? I think you're confused. I told you in any thiazide group of diuretics usually reduces their glomerular filtration rate, isn't it? Thiazide reduces glomerular filtration rate, whereas your eye sealing, that is your furosemide, will be causing increase in the glomerular filtration rate. Here what I am asking you, already there is hypertension crisis, already the patient is going to have a decrease in the glomerular filtration rate. If you are going to give further thiazide, what will it happen? It will be going, what happens when you are going to give thiazide diuretics? It is going to further decrease your glomerular filtration rate, and it is going to worsen your symptom and causes renal failure. So what is the drug you're going to give? Furosemide is a drug of choice. So furosemide is the one you're going to give, not your thiazide. If at all you don't have a choice, thiazide da irukku, furosemide illa, stock illa, I'm working in a peripheral system, I'm working in a primary health center, I don't have now, you can maximum give 25 mg per day of hydrochlorothiazide, not more than 25 mg per day. If you're going to give more than 25 mg, what happens is the patient will go into decrease in the GFR and renal failure. Then coming to the sixth one, that is going to be a chlorthalidone. Let's talk about this chlorthalidone. So chlorthalidone, then you are going to go, can also go for indapamide. So there are three drugs which you are going to remember as far as your hydrochlorothiazide and your moderate ceiling diuretic is concerned. Number one, hydrochlorothiazide. Number two, number one, write it down, hydrochlorothiazide. Number two, chlorthalidone. And what is the third drug? You have your indapamide. Now tell me, what are the uses of thiazide? The uses of thiazide is going to be, they are going to cause nephrogenic diabetes insipidus. They are going to be used in the nephrogenic diabetes insipidus. The drug of choice in the nephrogenic diabetic insipidus is going to be your thiazide group of diuretics. That's all about your thiazide group of diuretics and furosemide diuretics. Okay, your eye sealing diuretics. Now coming to the potassium channel diuretics. I think I have already explained you in detail regarding the mechanism of action. So this is going to block two important receptors. Either they can block ENaC receptor or they can go for blocking your aldosterone antagonist. Aldosterone antagonist is going to be a spironolactone. How is spironolactone formed? It is given as a prodrug called as candrinone. This candrinone gets converted to spironolactone. This does not act, this does not act on the luminal side. It is not going to act on the luminal side. It is going to go into your basement membrane of your tubule, and it is going to act there. So when it is going to act there, what are going to be the problem? I told you, they are going to block your sodium potassium hydrogen. So sodium potassium hydrogen block panna, more amount of sodium is going to get, what happens? What is going to be your aldosterone receptor antagonist? So antagonist, when you're going to do antagonist, what happens? Sodium is going to excreted more, because of that potassium and hydrogen will be absorbed more. So what are the side effects you're going to have? Hyperkalemia, metabolic acidosis. They are going to block your estrogen and progesterone, and they are going to cause decrease in the libido. Increase in estrogen is going, they are going to block your estrogen receptor. Because of that, by negative feedback mechanism, you are going to have more estrogen production, that is going to cause gynecomastia and menstrual abnormality. Now moving on to talk about the hyperpotassium. Whenever there's going to be hyperpotassium, what happens? So remember, when I am going to give a ACE inhibitor, so when I am going to give ACE inhibitor also, I am going to cause a side effect which is going to act on the hyperpotassium, which is going to act on the hyperkalemia, which is going to cause hyperkalemia. Therefore, never combine ACE inhibitors with your spironolactone. If you are going to combine ACE inhibitors, ACB inhibitors also causes hyperkalemia. When I am going to add a spironolactone to the patient, what happens? There is a excessive hyperkalemia in the patient. Now coming towards your amiloride and triamterene. Amiloride, triamterene, they are going to add on diuretics. They are going to be used on add-on diuretics and in your Liddle syndrome. What is Liddle syndrome? It is nothing but ENaC mutation. There is going to be increased sodium reabsorption. So இங்க என்ன பண்றோம், நம்ம sodium reabsorption prevent பண்றோம். That is what this your ENaC inhibitor. But what happens in your ENaC mutation in your Liddle syndrome? There is going to be increase in the sodium reabsorption. So that what happens, the child will have hypertension in the childhood itself. So what you have to do, do is you're going to give the patient with amiloride. Amiloride decreases the sodium reabsorption in your which area? In your distal convoluted tubule, because of that distal or collecting duct. In the collecting duct, because of that, what happens? There is going to be a reduction in the blood pressure in the child. This is called as Liddle syndrome. Very important question as far as your pediatrics is concerned. When you're going to go for your final year exam, pediatrics, Liddle syndrome is asked now itself, but you know what is Liddle syndrome. So you are very ahead of even the final year MBBS students. Once you're going to read your pharmacology very well, pathology very well, I can bet that you can even attempt your medicine paper. That will also be easy when you're going to be reading your pathology and your pharmacology very well. Okay, now moving on to talk about this eplerenone. Eplerenone is going to be aldosterone antagonist. So you have something called a spironolactone, but the problem with spironolactone is they are going to have a sexual disorder. They are going to have a sexual symptoms. So what you're going to do? So you're going to have another drug called as eplerenone, which is also going to be your antagonist, aldosterone antagonist, but they are going to be without any sexual side effects. So therefore, what happens is now eplerenone is used than your spironolactone. Now let's see which conditions all we are using all these drugs. So in any hyperaldosteronism, what you have to do? You're going to block your aldosterone receptors. So in your Conn syndrome or in cirrhosis, you're going to block your aldosterone receptor by giving eplerenone, or you're going to give spironolactone. And what is the drug of choice in resistant hypertension? When all the three drugs including diuretics are given, even then there is no improvement in the hypertension, then you go for the potassium sparing diuretics. Okay, then congestive heart failure. Okay, then another one it was there, that is called as finerenone. So you know, first one spironolactone, second one L-renone, third one is going to be finerenone. Finerenone is also going to be aldosterone antagonist. They are used to decrease the proteinuria in congestive in your chronic renal failure with diabetic mellitus. This can be asked as a one mark question. The drug of choice in patient having proteinuria, the drug of choice of aldosterone antagonist in the patient having proteinuria with chronic renal failure and diabetic mellitus. If they are going to ask you a similar sentence, the answer is going to be finerenone. Now coming to the carbonic anhydrase inhibitor, which you would have already known by this time. In eye, what happens? It is going to decrease the aqueous humor. In CNS, it is going to decrease the CSF production. And coming to your kidney, it is going to impact in the proximal convoluted tubule. There is going to be loss of sodium bicarbonate in the urine, leading to hypernatremia, metabolic acidosis, hyperchloremic metabolic acidosis, because chlorine level is going to be increased and a chlorine problem illa. So you're going to have hyperchloremic metabolic acidosis. Okay, and what happens here? You're going to have a so when the urine pH you're going to take it as alkaline, use is going to be acidic pH. So what happens is whenever your bicarbonate has to be increased, whenever you're going to take any acidic drug, so acidic drug ஏதாவது எடுத்துட்டீங்க, acidic poisoning, aspirin poisoning இருந்ததுன்னா அங்க what happens? You need to have more amount of bicarbonate in the urine. Then only you can excrete your aspirin metabolite very easily. So for that you can actually give this diuretics, the carbonic anhydrase inhibitor. Therefore that will help in acidic poisoning. You're going to go for the removal. Next comes your uric acid stone. So whenever there is a uric acid stone, whenever there is going to be a urine alkalosis, because of that will be decreasing the calcium stone. Okay, now coming to which all condition you should never use, that is going to be the first one, that is going to be your asthma COPD. What happens in asthma COPD? This carbonic anhydrase enzyme will be causing carbon dioxide retention, respiratory acidosis, okay, and they may worsen your already metabolic there is a metabolic acidosis. Okay, in a COPD what happens? The patient might also have respiratory acidosis. Because of that, what happens? It will worsen the symptom. And next is going to be hepatic coma. When the patient is going to have hepatic coma, ammonia is going to be more. When there is more ammonia, what happens? It is going to cause metabolic acidosis, and that patient may enter into coma. This is called as hepatic coma. Now coming to self-limiting diverse actions are there. Remember, it also has a self-limiting diverse action. Now, where all you're going to give this carbonic anhydrase inhibitor? Number one, in case of a nausea, okay, in case of your mountain sickness. So in mountain sickness, it is going to be a drug of choice. Similarly, in case of hyperventilation, like CO2 washout pananuna, so the CO2 washout asna, there will be a respiratory alkalosis. In that condition, what you will do, you will give this drug. Okay, well, now coming to the osmotic diuretics. What is osmotic diuresis? It is nothing but when you're going to have a rise in the intracranial pressure, or whenever there is going to be more amount of fluid present in your plasma. For example, in heart failure, you will go for a mannitol. Mannitol is called as osmotic diuretics. What it basically does is, it is going to draw out the water from your tissues in all your cavity, pulmonary edema, pericardial effusion, all those things. What happens? It is going to draw out the blood from your tissue. Because it is going to draw out the blood from the tissue, it is used in the normal angle glaucoma, and in your cerebral edema. In normal angle glaucoma and cerebral edema, this is used as a drug of choice. Okay, so and it is going to increase the plasma volume. So when you will be contraindicating in the congestive heart failure. So in the congestive heart failure, though it is going to help you in pulmonary edema, so what happens? It is going to draw blood from your tissues. When it is going to draw blood from the tissue, what happens? It is going to raise the volume of your plasma. So that is why it is contraindicated. Similarly, active CNS bleeding irukkrappa. For example, when there is a hemorrhagic stroke, okay, the patient is going to have an increase in ICP, but along with that, there is an active CNS bleeding. Then you will be having a leakage from your blood vessels. So that time you cannot give this drug. It is contraindicated. So that time it is contraindicated. Second thing, whenever the renal blood flow and GFR is raised. So whenever there is going to be impending renal failure, you can give mannitol. But in acute renal failure, when it is there, you are going to contraindicate. You should not give mannitol. So and then in dialysis, disequilibrium syndrome. In cerebral edema, you will go for mannitol. Hope you all will remember all these points. So with this, we are completing your diuretics, and we are going to go to something called as antidiuretics. Are you all clear till now? Any doubt till now? Do you have any doubt till now? So just see this image. So you are going to have carbonic anhydrase inhibitor, osmotic diuretics, loop diuretics, thiazide diuretics. So diuretics that is going to act only on the medullary part of nephron is going to be your loop diuretics. Okay, and diuretic acting on the collecting duct alone is going to be your potassium sparing diuretics. Eye sealing diuretics ketangana. These are 1 mark Viva questions. Eye sealing diuretics ketangana. It is going to be loop diuretics. Basolateral side of nephron. Diuretics of choice in the renal failure is going to be a loop diuretics. Thiazide safe in the renal failure is going to be metazolone. Remember, the only diuretics which is going, I told you that thiazides are not useful in the renal failure patient. But remember, there is one exception. So only one drug of thiazide you can actually give in the patient who is having less than GFR 40 also. Which is the drug you are going to give? Metalazone. Metalazone can be given in the patient who is having. So remember, metalazone can be given in the patient who is having less than 40 GFR also. That is called as your metalazone. Now, diuretic of choice in the calcium stones, you are going to give thiazide. Diuretic that preserve calcium is also thiazide. What are ototoxic drugs? Okay, remember your cisplatin, loop diuretic, antibiotic like your vancomycin, aminoglycoside, minocycline, AMB, and your NSAID. They are going to be ototoxic drugs. Now coming to the diuretic that you have to avoid in heart failure. Okay, the diuretic that you are going to avoid in when there is going to be a diuretic of choice in the raised ICP or your that is going to be a mannitol. Remember the drug which you are going to avoid in the heart failure, that is also going to be your mannitol. That is going to be a mannitol. Hyperchloremic, hyperkalemic metabolic alkalosis, which is going to cause hyperchloremic, hypokalemic metabolic alkalosis. Any idea? In which you are going to have hyperchloremic, hyperkalemic metabolic alkalosis. Let me see who is going to answer this question. Which drug causes hyperchloremic, hypokalemic metabolic acidosis? If you can answer this, you will be, I can very well understand that you have understood that full image. So whatever I displayed, that you would have understood. Can you just guess and tell me? Hypokalemic, okay, hypochloremic, hyperchloremic, hypokalemic metabolic acidosis. Can you tell which drug would have caused this? Afif, Ajay, Shivashira, Sanjeev, Shivaranjini. Can someone tell me which has caused, which would have caused hyperchloremic, hypokalemic metabolic acidosis? Can you just guess? Hyperchloremic. அப்ப hyperchloremic chloride observe ஆகல. Okay, chloride வந்து excrete ஆகல. There is no problem with the chloride channel. but there is a hypokalemic. Our potassium is going to be excreted out, and there is going to be a metabolic acidosis. Remember, it is going to be your carbonic anhydrase inhibitor. So hyperchloremic, hypokalemic metabolic acidosis will be presentation in your carbonic anhydrase inhibitor. What is the drug of choice of carbonic anhydrase inhibitor used in your mountain sickness? That is again acetozolamide. Drug of choice in your pseudotumor cerebri, that is also acetozolamide. And remember, the drugs that are going to cause gynecomastia, the drugs that are going to cause gynecomastia, the drugs that are going to cause gynecomastia are gynecomastia are disco drugs. What is disco drugs? DISCKO, digoxin, isoniazid, spironolactone, cimetidine, ketoconazole, omeprazole. These are the drugs that are used for these are the drugs that are causing gynecomastia. Clear, right? Disco drugs. So disco drugs are in a digoxin, isoniazid, you have your spironolactone, cimetidine, ketoconazole, and omeprazole. So remember, the uses of carbonic anhydrase inhibitor are glaucoma, alkalization of urine, metabolic alkalosis, mountain sickness, epilepsy, hypophosphatemia. So that's all. That comes to the end of the diuretics. Now coming to the antidiuretics. Remember, you have some vessels, you have something called as vasopressins. So you have something which is present called as vasopressins. They are going to be considered as antidiuretics. So you are going to have ADH. Okay, ADH na another antidiuretic hormone. So this antidiuretic hormone is going to come and sit on vasopressin receptors. What are the different vasopressins? You have V1, V2, V3. V1 is present in the blood vessels. Remember, V1 is present in the blood vessels. Then you have V2. Remember, V2 is present in the distal tubule. It is present in the endothelial cells of your vessel. Okay, it is present in the distal tubule. It is going to be present in the endothelial cells of vessel. And what is V3? V3 is present in the anterior pituitary. V3 is present in the anterior pituitary. Whenever there is going to be a secretion from your supraoptic or paraventricular nucleus to your posterior pituitary, your ADH is released. This ADH is going to act either on your V1, they are going to act either on your V2, or they can act either on the V3. Now, if it is going to act on the V1, remember, V1 is going to be again having V1A, V1B. So we have something called as, okay, V1A. We have V1B. Just remember this. V1A is going to be present in. So I told you already this. V1 is present in your vaso blood vessels. V1 is going to be present in the blood vessel. Adliye in the blood vessel abdin pathina V1A. It is going to be present in your blood vessels. Okay, they are going to be present in all your blood vessels. But V1B, this is going to be present in the pituitary. This is going to be present in the anterior pituitary. Very, very important. It is present in the anterior pituitary. V1A, it is present in the blood vessels. V1B, it is present in the anterior pituitary. Copy this down. Okay. Whereas your V2, it is going to be present in your kidney. It is going to be present in the collecting tubule. It is going to be present in the collecting duct, and it is also going to be present in the endothelium. If you ask me, the collecting duct is present in both your medulla as well as cortex. In which part it is going to be there? If you are going to ask me, endothelium. It is going to be present in the medulla more than your cortex. It is present in the medulla more than your cortex. Now coming towards the action of it. So remember, V1A acts by GQ type, whereas V1B, it is not going to be there. So V1A, what is the example of V1A? You have terlipressin. So do you remember, V1A is nothing but V1A. Remember, it is going to be a terlipressin. So this is going to be a selective V1 agonist. So where will you use this mechanism of action? In case of an esophageal varices, in an acute esophageal varices, when there is going to be excessive bleeding, what you can do? You can inhibit the bleeding by giving. You can inhibit the bleeding by giving what? By giving a V1A agonist. That is going to be a terlipressin. Clear, right? That is going to be the usage of terlipressin. Now coming to the V2. So V2 is going to be present in the collecting duct cells of your kidney and your endothelium. So what is the use when it is going to be present in the collecting duct? So this is going to cause rise in the water absorption. It is going to cause increase in water absorption. Whereas in endothelium, it is going to release. It is going to release factor 8 and von Willebrand factor. It's going to increase the factor 8 and von Willebrand factor. So now tell me, in which condition you use desmopressin? Desmopressin is going to be a selective. Desmopressin is going to be a selective V2 agonist. It's a selective V2 agonist. So it is going to be used as a drug of choice in diabetes insipidus and your nocturnal enuresis. Why? Because they are going to cause decrease in the water going into the urine. It is going to cause increase in the water resorption. That is going to be your desmopressin. And what is the other use? Von Willebrand factor and hemophilia A. Why? Because they are going to help in increasing the release of factor 8 and von Willebrand factor. Which one? Desmopressin. Therefore, desmopressin is used as a drug of choice in case of factor 8 deficiency and your von Willebrand factor deficiency. Can you tell me what is factor 8 deficiency called as? Can you tell me what is a factor 8 deficiency called as? Clotting factor 8 deficiency is called as what? Afif, Ajay, Shiva, Shivaranjani, can you tell me what is factor 8 deficiency called as? What is factor 8 deficiency called as? What is factor 8 deficiency called as? Can someone recollect and tell me? What is factor 8 deficiency called as? You all know the answer. Try to recollect and tell me. Hemophilia. Whether it is hemophilia A or hemophilia B. Factor 8. Factor 8 deficiency is called as, yes, it's a hemophilia A. So hemophilia A and von Willebrand disease. Other end desmopressin can be given as a treatment of choice or drug of choice. Now coming to the next one, terlipressin. You know what is terlipressin? They are going to be selective V1 receptor antagonist. So it is used in the treatment of acute variceal bleeding. You're going to use this in the treatment of acute variceal bleeding. Terlipressin is going to be selective V1 agonist. Okay, then your vasopressin. Vasopressin is going to be, again, they are going to be used in the norepinephrine resistant shock. Okay, this is all about your antidiuretics. Okay, that is good. This is all about your antidiuretics or your ADH hormone, antidiuretic hormone. Is it clear? Any doubt in this? Next, what you do in case of diabetes insipidus? What is diabetes insipidus? Remember, diabetes insipidus is nothing but there's a decrease in the ADH action. Because of decrease in the ADH action, there is going to be polyuria. There are actually two types of diabetes insipidus. Number one, central diabetes insipidus. Number two, you have nephrogenic diabetes insipidus. When it is a central diabetic insipidus, remember there's a decrease in the ADH release. Whenever there's a decrease in the ADH release, you can go for your desmopressin, because what your desmopressin does, it is going to cause, okay, increase your ADH release. But if the patient is going to have a nephrogenic diabetes insipidus, when the collecting tubules or collecting duct cells are going to be insensitive to ADH. When they are insensitive to ADH, and the receptor problem, V2 receptor problem. So நீங்க desmopressin கொடுத்தா கூட உங்க V2 receptor போய் function ஆகாது. அப்ப what is the drug you are going to give? You are going to give thiazide group. So in the nephrogenic diabetes insipidus, even though you give desmopressin for the patient, now you don't have a proper sensitivity in your V2 receptor. Therefore, you are going to give, instead of desmopressin, you give thiazide. So you know what is the action of thiazide? Thiazide is going to, where it is going to function? Can you tell me? What is the role of thiazide diuretics? Where it will be functioning? On the sodium chloride in your distal convoluted tubule. Because sodium chloride in the distal convoluted tubule, what happens? It is going to cause a paradoxical antidiuretic action. It is going to cause paradoxical antidiuretic action. Antidiuretic action. Is it clear? This is all about your diabetes insipidus. This drug thiazide is used in both central diabetic insipidus as well as your nephrogenic diabetes insipidus. So next we are going to have something called as syndrome of inappropriate ADH. So we are going to have something called as syndrome of inappropriate ADH. What is this syndrome of inappropriate ADH? What is this syndrome of inappropriate ADH? Very easy. Syndrome of inappropriate ADH means, write it down. Just write it down. Okay, what is called as your syndrome of inappropriate ADH? So just write it along with me here. Just put the heading syndrome of inappropriate inappropriate. We are talking about this for the long time. Inappropriate ADH or SIADH. Remember, here what happens? There is excessive amount of ADH. There is an excessive amount of ADH action. When there is going to be excessive amount of ADH action, what happens? Excessive amount of water is going to be reabsorbed. Excessive amount of water is going to be reabsorbed. This causes hyponatremia, euvolumia. So there is going to be euvolumic hyponatremia. This leads to dilutional hyponatremia. Otherwise, I can call it as a dilutional hyponatremia. Therefore, okay, so remember what you are going to do. You can either go for V1, V2. Both V1, V2 can be blocked. Both V1, V2 can be blocked. Otherwise, what we can do is we can selectively block your V2. Because when you're going to selectively block your V2, water reabsorption is decreased. So that is going to help the patient with SIADH. So what are the drugs that are going to cause a V1, V2 inhibition? That is going to be your conivaptan. And what is a drug that is going to inhibit only your V2? That is going to be number one, tolvaptan. And what is number two? We have something called as mozavaptan. These two are going to be oral drug, whereas conivaptan is going to be given by IV. There is something, the third drug which we have. Okay, there is something called as third drug which we have. So what is that? You have your demiclocycline. This demiclocycline, what it does is, it is going to make your CD, collecting tubule, collecting duct, insensitive to ADH. Do you remember where we saw this demiclocycline? Can you recall and tell me where we saw demiclocycline? Where did we saw demiclocycline? Any idea? Demiclocycline. What is the use of demiclocycline? Somewhere else we saw demiclocycline. It is a, what is it is? Yesterday we saw a fifth antimicrobial chapter. Demiclocycline. It comes under which group of antimicrobial? Okay, in which antimicrobial it comes into? Demiclocycline. In which antibiotic it is going to come into? What group? It's a tetracycline. Did you forget? Okay. Oh, I hope you all remember it. So we saw something called as tetracycline, protein synthesis inhibitor. So under the protein synthesis inhibitor tetracycline, we saw demiclocycline. We saw something called as demiclocycline. Do you remember, right? Do you all remember? Tetracycline or any contraindication? Anyone? Any point? Do you all remember? Demiclocycline. Any other point you wanted to add about your demiclocycline? It is going to cause nephrogenic diabetes insipidus. Always remember, demiclocycline causes nephrogenic diabetes insipidus. That's what we read in your tetracycline. Now I am just bringing that back here. So you can also have demiclocycline. What happens in demiclocycline? When I'm going to give demiclocycline in the patient, that is going to cause CD insensitivity to ADH. There is going to be excessive amount of water getting excreted. So that can be used as a treatment here. And apart from that, you are going to give IV 3% saline. You also go for IV 3% saline. This is all about the treatment of your syndrome of inappropriate ADH. So whenever you're going to get a patient with syndrome of inappropriate ADH, what is going to be your treatment? Close your eyes and tell. The first one is going to be your conivaptan. Conivaptan is V1, V2 inhibitor. What is V2 inhibitor alone? Tolvaptan and mozavaptan. And you're going to have demiclocycline and you're going to give 3% saline. Clear, right? So that's exactly what I have written. Remember, T stands for tolvaptan. T stands for toxicity. So it is going to be hepatotoxic in nature. So now we are going to move towards something called as cardiovascular system. Or do you have any doubt in this? Do you have any doubt in your diuretics? Do you have any doubt in the diuretics? the first 1 hour we have discussed the remaining topic which we had in your previous chapter, that is going to be your NSAID. Then we have started discussing about the diuretics. Now we are going to move towards the completed diuretics, antidiuretics. Now we are going to move towards the group of drugs called as cardiovascular system. Can we move into cardiovascular system? Can you all put in the chat box? Can you put a thumbs up, guys? Thumbs up, thumbs up. Can you all put a thumbs up? All the four, those who are staying here. Afif, very good. Ajay, Palpandi, Sanjeev, and Shivaranjani, are you all okay? Everything clear till now? Everything clear till now? Right? Clear, right? Okay, so we are going to move towards the next one, cardiovascular system. Remember, so you have the first and foremost important system, that is going to be your renin, angiotensin, aldosterone mechanism. What is this renin, angiotensin, aldosterone mechanism? Romba easy. Just remember, okay, you are going to have something called as renin that is secreted by the mesangial cells. You have juxtaglomerular apparatus. That juxtaglomerular apparatus and your mesangial juxtaglomerular apparatus is going to secrete something called as renin. What does this do to your angiotensinogen? Angiotensinogen is a large peptide that is going to break down your angiotensinogen into angiotensin 1. Who is going to break it? Renin is going to break it. That is the first step. Now, angiotensin 1 is going to get converted into angiotensin 2 by ACE, angiotensin converting enzyme. Now you have angiotensinogen 2. This angiotensinogen 2 will be converted into angiotensin. Angiotensin by what? By your, who is going to convert it from your angiotensinogen 2 into angiotensin. Angiotensin and 2 is going to go and it is going to sit on the angiotensin 1 receptor. And once it is going to go and sit in the angiotensin 1 receptor, what happens is there is going to be a vasoconstriction. Your blood vessels are going to get vasoconstricted. That is the first problem you're going to get. Second problem, they are going to release aldosterone. Number one, vasoconstriction. Number two, aldosterone. You know what are the function of aldosterone. Do you remember in collecting tubule in your kidney, you have something called as aldosterone receptor. When your aldosterone receptor is going to be activated, what happens? There is going to be an excessive amount of sodium getting reabsorbed. You're going to have excessive amount of sodium which is going to get reabsorbed, and you're going to have the remaining two. What are the remaining two which is going to be present? Excessive sodium gets reabsorbed, and you're going to have your potassium and hydrogen which is going to get excreted. You're going to have potassium and hydrogen going to get excreted. That is what we read in your aldosterone mechanism. So this is called as renin angiotensin aldosterone mechanism. Now, this is a main reason for increase in the blood pressure in our body. Now, what we can do is we can inhibit this aldosterone receptors. How to inhibit the aldosterone receptor? So, aldosterone receptor inhibitor are going to be from the end I'm coming. So, aldosterone receptor eppadi inhibit panna by giving us spironolactone. So, this spironolactone, when you're going to inhibit, what happens? There is going to be increased sodium, potassium, sodium and water excretion in the blood. Therefore, there is going to be decrease in the BP. Number one. Number two, what you can do? You're going to give you're going to give angiotensin receptor blocker. When you're going to give angiotensin receptor blocker, what happens? Angiotensin 2 cannot come and act in the angiotensin receptor. Therefore, you're going to inhibit this vasoconstriction and decrease in the BP. Point number two. Point number three, you can inhibit this ACE. That is called as ACE inhibitors. So you have a certain group of drugs which are going to be called as ACE inhibitors. Number four, you can inhibit the renin secretion itself. How you are going to inhibit the direct renin? By aliskiren. Aliskiren is a drug that is given to directly inhibit your renin level. Clear, right? So remember, another point is, so renin is going to be secreted by your beta 1. Okay, so this beta 1, if you okay, beta 1 cells of your kidney. So if you want to inhibit this beta 1, you can go for a beta blocker. You have something called as beta blocker, right? That is going to be a propranolol, all your LOL group of drugs. So LOL group of drugs can be used to inhibit your beta okay, beta cells in your kidney. And number 6, what you're going to remember is this beta cells, whenever you're going to inhibit, so this beta cells, whenever it is going to secrete your renin, what happens? It is going to decrease your prolactin. It's going to decrease your prolactin. Okay, there is one more problem. Beta cells, so prolactin, they are interlinked with each other. Okay, they are interlinked with each other. That's all I want to tell you. That's all I want to tell you. Now coming towards, so when it's going to decrease your prolactin level, okay, when you're going to give aliskiran, that is going to inhibit your renin. When it is inhibiting your renin, what happens? There is going to be a decrease in the prolactin level. Therefore, this is contraindicated in pregnancy, and this is going to be a contraindicated in pregnancy. That I want you to remember. And also, you're going to remember that there is going to be this is going to be used as an anti-hypertension drug. All the drugs whichever we discussed now is used as a anti-hypertension drug. And this is also going to help you to prevent cardiac remodeling. What is this cardiac remodeling? Remember, what happens is whenever there is going to be hypertrophy of heart, whenever there is going to be hypertrophy of heart, there is going to be a decrease in the cardiac output. So because of the cardiac output decreased, that is going to nothing but your congestive heart failure. In congestive heart failure, if you're going to leave it alone, what happens? There is going to be more amount of all your kinin, all your peptidase present. When you're going to leave this peptidase, everything, what happens is it is going to cause hypertrophy, excessive hypertrophy of heart nadako. So adinal neenga enna pandreenga, you're going to prevent by giving your ARB or ACE inhibitors. So if you're going to give ACE inhibitors or your ARB, what happens is they are going to inhibit your conversion of your angiotensin 2 to your action. So அதை நம்ம prevent பண்றோம். But what is the side effect is when you're going to inhibit your angiotensin converting enzyme, this is the same drug that is going to break your bradykinin also. So now what happens? There is an excessive increase in the bradykinin level. So bradykinin increase ஆகும்போது that leads to cough and angioedema. That is going to be your ACE inhibitor induced cough. ACE inhibitor induced cough. Okay, that is called as your ACE inhibitor induced cough. Clear, right? So now, what are the ACE inhibitors? All the drugs that are going to end with pril, captopril, enalpril, lisinopril, perindopril. We have a very big pril group of drugs which you can see in the Tripathi textbook. Okay, so that is going to be a pril group of drugs. Remember, all ACE inhibitors are going to be a prodrug. Prodrug, you're going to give one drug that is going to get metabolized and give you other product. That is called as your prodrug. Clear, right? What is prodrug? Now you understand what is prodrug, isn't it? So it is going to be a prodrug. That is the first one. Second thing you have to understand is going to be, you're going to have a captopril, lisinopril. You're going to have something called as captopril. You're going to have something called as lisinopril. These two drugs alone, they are going to be not a prodrug. They are not going to be prodrug. Remember, captopril and lisinopril, they are not going to be prodrug. They are going to be directly acting. Now, second point, all our renal elimination, all your pril group of drugs, that is going to be ACE inhibitors, are going to have a what elimination? Renal elimination, except your fosinopril and your moxapril. Except your fosinopril and your moxapril. These two drugs alone will get eliminated by your liver. They get eliminated by your liver. Since these both are going to be eliminated by your liver, what you have to understand is these two are safe to give in the renal failure. So whenever you're going to have a renal failure, these two drugs are safe to give. What are the two drugs that are safe to give? Number one, it is a fosinopril, and number two, it is going to be a moxapril. Okay, it's going to be a moxapril. Okay, clear, right? Now coming towards the shortest acting drug and longest acting drug. You have to remember that captopril is a shortest acting drug, and your ramipril, perindopril is going to be your longest acting drug. So with this, we are ending the first group of drugs, that is going to be ACE inhibitors. Next, we are going to have your ARB. What is ARB? It is nothing but your aldosterone receptor. It's nothing but your angiotensin receptor blocker. This angiotensin receptor blockers, you're going to call it as sartan. Like how we call it as group of drugs for ACE inhibitors. Here all the drugs are going to end by the term sartan. So you have your losartan, irbesartan, candesartan, telmisartan, valsartan, all are going to end with the terminology called as sartan. Okay, now coming to the losartan. Losartan is going to have a uricose-uric action. Okay, therefore, what happens is it is going to reduce the uric acid level in the blood by increasing the uric acid level in the urine. So, what is the benefit of it? This is going to be used as one of the drug in case of gout. I already told you when I am talking about your DMARD group of drugs as well as the drugs when I am going to talk about in the gout. When I was talking in the gout, I was telling you there are some drugs which you can give in the patient who is having BP plus gout. When the patient is going to have blood pressure, hypertension, and your gout, then what is the treatment of choice? You're going to give losartan for the patient. And thromboxane A2 antagonist. They are going to behave as a thromboxane A2 antagonist. So they also have an additional effect of antiplatelet action. They are going to have additional effect of antiplatelet action. They are going to also function as a antiplatelet drug. They are going to be also functioning as antiplatelet drug. Very important. They are going to function as antiplatelet drug, and this is used in the prophylaxis of stroke. Remember, this is going to be used in the prophylaxis of stroke. That's all. That comes to the end of discussion of your losartan. Then comes your candesartan. Candesartan is used as a anti-migraine action. Candesartan is used in the as a anti-migraine. They are going to be used as anti-migraine. What is the third one? Telmisartan. Remember, telmisartan, it is going to be excreted by your bile, so it is safe in the renal failure. Can you tell me in the chat box what are the two drugs that are going to be having a liver excretion and not renal excretion in case of your ACE inhibitors? Can you tell me in the chat box? Can you tell me in the chat box? ACE inhibitors. What are the two ACE inhibitors which is going to have a, which is safe in the renal failure? Which is safe in the renal failure? Moxapril and fosinopril. Excellent. Same way, there are the drug which is going to be safe in the renal failure in your ARB is going to be your telmisartan. It is going to be a telmisartan. And the question of Medico. What is your name? I don't know. Kindly post your name and which college if you want to. Okay, if you want me to just send the notes, you can send me in the chat box or in my chat box or in your WhatsApp also. You can send me so that I'll send you the notes everywhere. Anyway, today evening after completing everything, I'll send you all the notes, whatever I'm just annotating here. Okay. Okay. Now coming towards the valsartan and your telmisartan. In addition to the usual action of blocking your aldosterone, your angiotensin receptor, it is also block your PPAR4. Can you tell me what PPAR4? PPAR4 alpha enga use pandrom, PPAR4 gamma enga use pandrom. Let me see who's going to answer. PPAR alpha is used in inhibiting your PPAR alpha is going to be used in PPAR alpha agonist is used in which disease? PPAR gamma is used in which disease? Diabetic, okay. Diabetic, edila? PPAR gamma va, PPAR alpha va? Which one we will be using? We have two drugs, PPAR gamma we have, then we have PPAR alpha. PPAR alpha வந்து எங்க use பண்றோம்? No, Palpandi, it's not. PPAR gamma is diabetes, exactly. BPAR gamma is diabetes. BPAR alpha is going to be your fibrate group of drug. PPAR alpha is nothing but your fibrate group of drug which we use in the hyperlipidemia. Whereas your PPAR gamma where we are utilizing anti-diabetic drug. What is the group of drug called as? Thiazolidinedione. Thiazolidinedione. So that is the drug group of drug that is going to be PPAR4 alpha. So in a patient who is going to have a hypertension, in a patient who is going to have a diabetes, in a patient who is going to have a hyperlipidemia, what is the effective group of drug you can give? That is going to be your telmisartan. So when I'm going to tell you a 65-year-old patient who is going to have diabetes, hypertension, hyperlipidemia, as well as a renal failure, when I'm giving you a similar history, what is the drug of choice you're going to follow here? You're going to follow telmisartan, because telmisartan is renal failure safe. It is going to be anti-diabetic. It is going to be anti-hyperlipidemic. It is also going to be anti-hypertensive. A very important point I want everyone to know. Now coming towards the side effects. So what are the side effects of your ACE inhibitor? Just remember captopril. Captopril mattum number panunga. Adila PR mattum da contraindication. What are they? C stands for cough. C stands for cough, and your A stands for angioedema. These two, captopril is going to be a ACE inhibitor. So why there is going to be in a cough and angioedema? Because of rise in the bradykinin level. So in that case, what will be your drug of choice? You go for A or B instead of ACP, or இது ரெண்டுமே இல்லாம வேற ஏதாவது ட்ரக்கு நம்ம போய்க்கலாம். Next is your P. P stands for increased potassium loss. So increased potassium in the blood, that is going to be hyperpotacalemia. So what is the contraindication? So you should never give potassium sparing diuretics along with captopril, because captopril is also going to cause hyperkalemia. If you're going to give potassium sparing diuretics, potassium will also get increased in your plasma. That is going to lead to very high hyperkalemia, very severe hyperkalemia. So contraindication with potassium sparing diuretics. Next is going to be T. T stands for taste disturbances. O stands for orthostatic hypotension. Okay, and R stands for pregnancy. So in pregnancy, you should never give, because they can lead to teratogenicity. What is R? Renal artery stenosis, bilateral renal artery stenosis. Therefore, in bilateral renal artery stenosis, you should never give ACE inhibitors or ARB. Both are contraindicated in bilateral renal artery stenosis. Clear, right? Next comes to the next point. That is going to be your I. I stands for increase in the insulin sensitivity. So they are going to cause increase in the insulin sensitivity. Therefore, only ACE inhibitor. Okay, hypoglycemia. It can lead to hypoglycemia because ACE inhibitors, it's going to increase the insulin sensitivity, and what happens is they are going to cause hypoglycemia. More amount of insulin sensitivity, more amount of glucose gets utilized, that leads to hypoglycemia. So diabetes patient on sulfonylureas, so on insulin, when you're going to give I, that is going to be your captopril in this patient, ACE inhibitors, what happens? They will lead to this problem. And finally, L stands for LOL. LOL means red. So in Hindi, LOL means red. So red rash will be there. So these are the side effects and contraindication for your captopril or ACE. Okay, so clear. Even in A or B, you're going to have similar, but one or two exclusion will be there, as I have told you in this itself. So you can be managing to write the side effects for your ACE inhibitors. You can manage to write the side effects for your ARB. Both can be done. Is it clear? Is it clear? Any doubt? Do you have any doubt? Can you tell me? No, right? Hope you don't have any doubt, right? Yes. Now moving towards the next one, that is going to be the uses of ACE inhibitors or ARB. Both are equally efficacious. So ACE inhibitors and ARB blockers, they are going to be, both are going to be effectively, both have equal efficacy. Hypertension, first line antihypertensive drug. So remember, your ACE inhibitors are used as a first line antihypertensive drug. In a mild to moderate, you go for ACE inhibitors or ARB oral. In the hypertensive crisis, you go for enalapril. Enalapril is going to be a IV drug of choice. Okay, why this is even if you're going to give enalapril kudta kuda, that is going to get converted to enalaprilat. That is the one which is going to active compound. Okay, so in IV means you can directly give the active compound. Now, what are the advice? So they are safe in the asthma. The advantages, they are safe in the asthma. You can give in the diabetic mellitus. You can give in the gout. Clear? Now moving towards hypertensive crisis. So hypertensive crisis in scleroderma, you can give the ACE inhibitors. Now coming towards your congenital heart failure, in the congestive heart failure, in the first line, you can give this drug. Okay, remodeling decrease pannu, morbidity decrease pannu. Next, diabetic nephropathy. In case of diabetic nephropathy, there is going to be mesangial proliferation in the long-standing diabetes mellitus. Albumin urea will be, okay, albumin urea, adalla vella varudhu. So diabetic, when there is going to be albumin urea, then what you're going to do? You're going to give a ACE inhibitors. This will be helping you. Okay, now what are the drug of choice? So ACE and ARB, they are going to be renoprotective because they decreases your mesangial proliferation and they are going to decrease albumin urea. Therefore, diabetic patient, hypertensive patient, okay, with a hyperlipidemia, with renal failure, what is the drug you're going to give? Come on. What is the drug you are going to give? Diabetic, hypertensive, and along with that, you are going to give your hyperlipidemia, and along with hyperlipidemia, there is going to be a renal failure. What is the drug of choice? What is the drug of choice? Who is going to tell what is the drug of choice? Diabetes, hypertension, hyperlipidemia, and renal failure. What is the drug of choice? Tell me, Sartan. Very good. Similarly, when the patient is going to have diabetes and you're going to ask what is the diabetic drug that is going to be a renoprotective. This also I told you in the endocrinology yesterday. So diabetic mellitus patient who is going to have a diabetic mellitus patient like the drug will be called as renoprotective drug. Remember, it is SGLT2 inhibitor, dapagliflozin. Dapagliflozin is a drug that is called as renoprotective anti-diabetic drug. You should never forget. So, renoprotective antihypertensive drug in ketagana, that is ACE inhibitors or ARB. Renoprotective specific, it's going to tell me Sartan. If they are going to ask renoprotective anti-diabetic drug, the answer should be your dapagliflozin. Clear? Now coming towards your first chapter, that is going to be your congestive heart failure. So what is congestive heart failure? There is a decrease in the cardiac output. There is going to be a congestion mainly in the lungs. That is called as congestive heart failure. Why do we call it as congestive heart failure? Because of the left ventricular failure, there is an excessive amount of blood is going to go through your pulmonary vein into your lungs. Here there is going to be a congestion of blood inside your lung alveoli. So that leads to pulmonary edema. So when a congestive heart failure with decrease in efficacy of your left ventricle, so that is going to be a chronic problem. The patient will be having a dyspnea, the patient will be having a peripheral edema, increased JVP, and what is JVP and other things. If you don't know, try to not to learn now because it's an exam time. Just learn it is increase in JVP. Increase in JVP occurs due to increase in the right ventricular pressure. Just remember like this. This is more than enough. Okay, so what are the drugs you're going to give? You're going to give oral drugs. So what is a oral drug? Remember, in the case of acute congestive cardiac failure, in case of acute congestive heart failure, the first drug of choice, if they're going to ask you, remember it's going to be a ACE inhibitor. Along with that, you will be giving beta blockers. This is going to be the first drug of choice in case of acute congestive heart failure. Okay, but you can also go with the drugs like diuretics like your furosemide. This is going to, and your RAS inhibitor, that is going to be AC inhibitors, ARB, ARNI. Then you're going to have your beta inhibitors, that is going to be a propranolol. Remember, so ARNI, what is ARNI? Can someone tell me? Any idea what is ARNI? What is ARNI? Any idea? ARNI. What is ARNI? Angiotensin receptor neprilysin inhibitor, a very important in recent time. I can give you a 3 to 4 stars that can be asked in your exam. ARNI means very recent update. Okay, ARNI means angiotensin receptor neprilysin inhibitor, that is called as your ACE, that is called as your ARNI. What is an example of neprilysin inhibitor? Sacubitril. So it's not salus, this spelling is wrong, I'll write again. Sacubitril. It's sacubitril. That is going to be the example. Sacubitril is a A or angiotensin receptor neprilysin inhibitor. Sacubitril. Okay, if you are not controlled with 1, 2 and 3, diuretic கொடுத்துட்டேங்க, RAS கொடுத்துட்டேங்க, beta blockers கொடுத்துட்டேங்க. இத கொடுத்தக்கு அப்புறமும் if the patient is not going to have a development, then what you're going to do? You're going to give spironolactone. Spironolactone, only diuretic that is going to decrease the mortality, not morbidity. Morbidity decrease பண்ற drug is going to be ACE, ARB. But which decreases mortality, if they're going to ask you, that is going to be your spironolactone. And your SGLT2 inhibitor. What is SGLT2 inhibitor? Can you name a SGLT2 inhibitor in the chat box? Can you name a SGLT2 inhibitor in the chat box? Let me see who's going to tell. SGLT2 inhibitor in the chat box. Can you tell me? Dapagliflozin. Any other drug? Verum oru drug dana. Dapagliflozin. Okay. Maybe other drug? Can you give some other example? Just canagliflozin. Very good. So canagliflozin is also another drug. Now coming to bidil drugs. What is bidyl drugs? Bidyl drugs are nothing but when you're going to add hydrolysine along with it isosorbide dinitrate. So hydrolysine and isosorbide dinitrate is called as bidyl drugs. So this bidyl drugs normally American, African and black people will be taking because they are very prone to develop hypertension. Okay, the prophylaxis we are using. And ivabradine. Ivabradine is a direct bradycardia. There will be ivabradine is going to be another drug that is going to be increasing the heart rate, but the problem is they are going to cause direct bradycardia. Okay, in the direct bradycardia, you are going to use ivabradine. This will be increasing the heart rate. Okay, it is going to increase the heart rate. It's going to increase the heart rate. Now, digitalis, nowadays digitalis is not used. But you have to know why digitalis is not used. What is the mechanism of action? Let's see the first drug, digitalis. So remember, digitalis is nothing but digitalis. You are going to have a very important function. Okay, you're going to have sodium, potassium transporter and your sodium calcium transporter. ரெண்டு transporter இருக்கு நம்மளோட heart cellsல. ஒன்னு sodium potassium ATPase, இன்னொன்னு sodium calcium antipode. Sodium calcium antipode. Clear? So first one வந்து பாத்தீங்கன்னா sodium potassium ATPase. What happens in the sodium potassium ATPase? So your digitalis is going to go act on the sodium potassium ATPase and they are going to inhibit your sodium potassium ATPase. When it is going to inhibit the sodium potassium ATPase, what happens? There is going to be huge buildup of total amount of sodium present inside your cardiac cell. Okay, now what happens? It is also going to block a calcium sodium exchanger. So when it is going to block your calcium sodium exchanger, now again what happens? The calcium also cannot go outside. Now already sodium is more. Now there is a more calcium also inside. So when there is a more sodium, more calcium, what happens? It is going to cause increased depolarization. You know that whenever there is going to be a sodium or calcium, it leads to depolarization. So there is an increase in the depolarization and this rise in depolarization is going to cause increased force of contraction. Okay, increased force of contraction. Is it clear? Increased force of contraction. Clear, right? So this is a very important point. Now, when you're going to block the digitalis, it is going to cause increased force of contraction. But apart from it, what was the other problem that was there? One, it is going to act as it's going to act as inotropic in nature. Onset is slow, full response occurs in the 5 to 7 days. This is called as time to digitalization. This is called as time to digitalization. So this leads to hypokalemic or hypokalemic patient. So whenever there's hypokalemia, more site for binding your digitalis will be there. So digitalis can bind to more site and normal dose can become toxic. So hypokalemic patient, already the patient is hypokalemic. So already amount of potassium available to your cardiac myocyte is going to be decreased. Cardiac cell is going to be decreased. Now what you are doing? You are going to add digitalis. Now digitalis will be further preventing your potassium entry into your cell. Because of that, what happens is even a small dose of digoxin may cause toxicity. Now moving on to the second problem, it is going to decrease your AV conduction. So AV conduction is decreased. Because of that, what happens? There is a vagomimetic effect. So your vagus nerve is the one that causes decrease in the AV conduction. This digitalis toxicity is also going to cause a vagus similar to vagus-like action. Therefore, they increase the refractory period in the AV node. So there is a decrease in the impulse from your atrium to ventricle, decrease in the heart rate. So first நான் சொன்ன initial periodல force of contraction increase ஆகும்போது heart rate increase ஆகும். But afterwards what happens? Slowly your AV conduction is going to be decreased. Because of that, what happens? Heart rate will also start to decrease. In ECG, what you have? I told you that there is going to be less AV conduction. Up AV conduction, your P is going to be P is the one that is going to be in your ECG. Your P is going to denote what? Atrial contraction. So atrial contraction is otherwise called as sinoatrial node impulse. It is going to go to your AV node. In the transfer period is going to be from SA node to AV node. From AV node, what happens? It has to go to bundle of His and Purkinje fibers. Now what happens is this travel from your SA node into your your all your ventricles. Thus time is called as PR. This PR time is going to be increased. Your PR time is going to be increased. But what happens? QT time, that is going to be ventricular depolarization. So depolarization ஆகுது, அப்புறம் repolarization ஆகணும். அந்த repolarization என்ன ஆகுது? இங்க ஆகாது. அதனால there is a decrease in the QT interval. So there is an increase in the PR interval, there is a decrease in the QT interval. Because of that, what happens? Your T wave will be flat. Why T wave is flat? Your ventricular repolarization is not going to occur. When there is no ventricular repolarization, ventricular repolarization does not occur. What happens? There is going to be a T wave flat, and your ST segment is also getting decreased. Your ST segment is again going to be the time taken for your repolarization. That is also going to decrease. Depolarization time is increased, repolarization time is decreased. Depolarization time is going to be your PR interval, your QT interval is going to be your repolarization time, and T wave is exactly denoting your repolarization, which is going to be flat in this condition. Now moving on to talk about the digitalis. Digitalis, you're going to have digoxin and your digitoxin. Remember, digoxin, digitoxin. Digitoxin is no longer available. Now there is no digitoxin available, only digoxin adume we are using very in a less conditions. Okay, it is going to be eliminated by renal, it is going to be eliminated by hepatic. 40 hours T off, 5 to 7 days T off. It is used in acute heart failure and chronic heart failure. This was used, I should name it as, this was used in the maintenance of chronic chronic heart failure. And coming to, this is going to be 10 mg per ml. This was given 0.5 to 0.8 nanogram per ml. And what is going to be your side effects? Remember, the first side effect is going to be your nausea, vomiting, pain. Next is a xanthopsia. They are going to cause yellow color vision, digoxin, and it is dizziness, and it is going to cause your gynecomastia. Second thing, it is going to increase the heart rate initially. So whenever there's an increase in the heart rate initially before AV conduction decreasing, so that is going to lead to ventricular bigeminy. How do you treat this ventricular bigeminy? We are going to treat the ventricular bigeminy by giving lignocaine more than your phenytoin. You are going to give lignocaine more than your phenytoin. What is the second thing? AV block. In your atrioventricular block, you are going to give atropine for the patient, or in case of you are going to increase the cardiac pacing. So contraindication is going to be a DC shock. Third, severe toxicity. Digoxin severe toxicity you can go for a anti-digitalis antibody. So this is called as your digiband. This is called as your digiband. These are the things which we perform if there is going to be a toxicity because of digitoxin. So what are the reason for toxicity in the digitoxin or digitalis? There is going to be electrolyte imbalance like hypokalemia, hypomagnesemia, hypercalcemia. In the madri problem this digitalis will be causing a toxicity. And what are the drugs which you are going to give? So glycoprotein, P-glycoprotein. Remember, there is something called as P-glycoprotein inhibitor. When this P-glycoprotein inhibitor, what happens? It is going to decrease the elimination. For example, when you're going to give amiodarone, clarithromycin, or quinidine, when you're going to give these drugs along with your digitoxin, what happens is that will be reducing the elimination of your digitoxin, and that will finally lead to toxicity of digitoxin. And similarly, in an elderly patient, in a patient with hypothyroidism, in the patient with carditis, already they are going to have a problem. When you are going to add digitoxin in these patients, what is going to be the problem you are going to get? Because of that, you are going to get a extra sensitivity to your digitalis. So where alone you are going to use digitalis? Again, repeat along with me. The only one place where you are going to use digitalis right now is your congestive heart failure along with atrial fibrillation. Apart from that, you are not going to use digitalis in any other condition. So it is going to be used only in your congestive heart failure, and when it is going to be coexisting with your atrial fibrillation. Coming to the third drug, that is going to be increase in the calcium. That is going to cause increase in automaticity, and it is going to cause increase in the atrial contraction. So remember, whenever there is going to be increase in the atrial contraction, okay, whenever there is going to be atrial contraction, what happens? Very simple. Whenever atrial contraction increases, it is going to cause atrial fibrillation. So whenever atrial contraction is going to be there very fast, what happens? That is going to lead to AV nodal block. Whenever AV node is going to be blocked, that is going to decrease the impulse that is transmitted from your ventricle into your bundle of and Purkinje fibers. From your AV node into bundle of and Purkinje fibers is going to be blocked. Because of that, you're going to have a problem. Now, most characteristic arrhythmia which you're going to get is not ventricular tachycardia. You're going to have tachycardia, but what type of tachycardia? Because of rise in the atrial contraction. That's why you call it as a atrial tachycardia will be there, and variable heartbeat. So it is not going to be very similar. It is going to be a variable heartbeat. Clear? What are the contraindications? As I already told you, in WPW syndrome. What is WPW syndrome? Wolff-Parkinson-White syndrome. This is your AV node. This is going to be a ventricular node. You are going to have three pathways for the transmission of impulses. So in Wolff-Parkinson syndrome, Wolff-Parkinson-White syndrome, what happens? There is going to be a blockage of this transmitting routes. Because of this, what happens? You are going to have some problem. What are those problems? That is what occurs in your Wolff-Parkinson-White syndrome. I don't want to go in detail, but remember, Wolff-Parkinson-White syndrome, your drug that is going to be your what drug? Digoxin is a contraindicated. Then what are the places where you are going to use? What are the places where you are going to use the drug digitoxin or digoxin? Number one, you are going to use the congestive heart failure, atrial fibrillation, and to control the ventricular rate. When you are going to control the ventricular rate, how you are going to control? By blocking the AV node. If you are going to block your AV node, you can control the ventricular rate. What are the other drugs that are used to block the ventricular rate? The beta blockers can be used. Verapamil can be used. What is verapamil? Verapamil is a calcium channel blocker. You know, right? Verapamil, diltiazem. There are two drugs. Now coming to the convert AF. So how to convert your AF into sinus rhythm? By giving a class 3 antiarrhythmic drugs. Now tell me again, I'm repeating, whenever you're going to have a congestive heart failure with atrial fibrillation, that is the only place where you are going to give digitoxin. Clear, right? Whenever you're going to get a congestive heart failure along with a stable symptom, there is no heart failure, okay, well, there is no atrial fibrillation. Now you are going to get stable symptom. Then what you're going to do is you're going to stop the treatment, okay? Or in case of acute MI or arrhythmia or infection, in all these cases, you are going to stop the treatment. Never continue with your digitoxin. Clear, right? So if you're going to continue with digitoxin, what happens? They will worsen the symptoms like dyspnea, trust. There will be a pink froth sputum, air hunger, and bilateral vessel crepitation will be occurring. Now, moving on to talk about the acute left ventricular failure. Do you have any doubt in digitoxin? Will you be able to write in the exam digitoxin? Will you be able to write digoxin in the exam if they are going to ask you digitalis or digitalis toxin? a loop diuretic. Excellent. So loop diuretics, when you're going to give, what it is going to be doing, it is going to excrete all your sodium and all your water. That means the total amount of volume of blood present inside our body will be reduced. That is going to reduce the workload. That is going to reduce the workload of your left ventricle. So that is the first thing how you are going to do. Second thing, why do you give IV morphine? Anyone know why do you give IV morphine? What is the function of IV morphine? Why do you give IV morphine? Any idea? It is going to reduce your pain, anginal pain. That is going to be reduced. Third thing is going to be IV vasodilator. Why do you give IV vasodilator? You are going to increase the vasodilation. So you are going to increase the dilation of your blood vessels in your peripheral circulation. That means what happens? It is going to reduce the venous return into your heart. That it is going to decrease the workload of your heart. What are the drugs you are going to give as IV vasodilator? Nitroglycerin, nitroprusside, and nesiritide. Okay, these are the three drugs which you give. These are the three IV dilators which you are going to give. Number 4, we are going to increase inotropes. So why do you give inotropes? Very easy. You want to increase the force of contraction. You want to increase the force of contraction. If you want to increase the force of contraction, what is going to be the type of receptors present in your heart? Beta 1 receptors. So you wanted to give beta 1 receptor agonist in order to increase the heart rate. So what are the example? Dopamine, dobutamine, noradrenaline. You can go for dopamine, dobutamine, or noradrenaline. Next, you are going to have inodilators. What is this inodilators? You have this vasodilating property. Along with that, we have a inotropic property. Which one has? All your PDE, phosphodiesterase 3 inhibitors. So all your phosphodiesterase 3 inhibitors will have a inodilating property. What are the examples of inodilator? Number 1, amidinone. Number 2, amrinone. Number 2, mildrinone. Number 3, inoximone. What are the three drugs? Amrinone, mildrinone, inoximone. These are the 4 drugs which is going to be used as inodilators. But remember, they have a side effect. What is the side effect? Thrombocytopenia. There is going to be decrease in the platelet count. Now coming to the next one, levosimendan. What is this levosimendan? They are going to have 2 functions. 1, calcium channel sensitizers. Number 2, phosphodiesterase inhibitor. And finally, the last one, that is going to be your digoxin. Clear, right? Then we are going to talk about something called as BNP therapy. What is BNP therapy? See, your brain natriuretic peptide. What is this brain natriuretic peptide? Remember, your body inherently, okay, your cardiac muscle, whenever it is going to have a increased workload, whenever there is going to be any injury to your ventricle, what it does is, it is going to produce as a substance called as brain natriuretic peptide. Clear? This brain natriuretic peptide is going to cause a sodium loss in the urine. Okay, அப்ப யூரின்ல சோடியம் லாஸ் என்ன ஆகும்? வாட்டரும் வெளில போகும். இப்ப சோடியம் வாட்டர் ரெண்டும் வெளில போச்சுன்னா it is going to cause decrease in congestion. Number 1. And number 2, they cause vasodilation. How brilliant is our body, you see. So உங்க heartலயே inherent there are some endogenous molecule called as brain natriuretic peptide. Whenever your ventricle is going to stress, myocardium is going to get stressed, they are going to release this brain natriuretic peptide. So they are going to cause decrease in congestion and they are going to cause increase in the cardiac output. So this brain natriuretic peptide, நம்ம இப்ப என்ன பண்றோம்னா, we are going to give a recombinant brain natriuretic peptide. But if it is going to be a normal brain natriuretic, no problem. But when you're going to give a recombinant brain natriuretic peptide exogenously from our body, brain natriuretic peptide secreted by your endomyocardium is not sufficient enough. So நம்ம external கொடுக்கலாம்னு சொல்லிட்டு some scientists got this idea and he started to give recombinant brain natriuretic peptide. But what was the problem is nesiritide. The drug name is nesiritide. It is a recombinant brain natriuretic peptide. He gave this drug, but the problem was this brain natriuretic peptide gets broken down by a substance called as neprilysin. The substance called as neprilysin. So what you have to do? You have to inhibit this neprilysin also. What does NEP? NEP stands for neutral endopeptidase. So you have to inhibit this neprilysin enzyme. You have to inhibit this neprilysin enzyme. It is not going to increase the cardiac output, Pandi. It's not going to increase cardiac output. But what it is going to do is, when there is a vasodilatation, the venous return decreases. When the venous return decreases, the amount of blood that is going to enter into your right atrium decreases, right ventricle decreases, pulmonary artery decreases, from your pulmonary vein to your left atrium decreases. So finally, the amount of blood that going to come to your left ventricle is also decreases. Now, when the amount of blood that comes to your left ventricle decreases, your left ventricle will have a less work compared to that of previously, when more amount of blood is going to come into your left ventricle. So here now, what the workload of your left ventricle decreases. Already you're going to have a left ventricular failure. When there is a more workload, your left ventricle is going to further worsen. So you're going to reduce the workload of left ventricle. Now hope you am clear. Now I hope that you can understand why there is going to be a vasodilatation helping in the heart failure. Clear, right? Now you have the brain natriuretic peptide that is going to be your nesritide, that is going to be broken down by your neprilysin. This neprilysin can be inhibited by a substance called as neprilysin inhibitor. What is neprilysin inhibitor? You have sacubitril. Remember, sacubitril is a drug you can give to inhibit the neprilysin. This sacubitril is an oral drug. Your use is going to be chronic heart failure, and it is continued always with the valsartan. You can always continue with the other drug, that is going to be a valsartan. So valsartan plus sacubitril, it is called as ARNI. We have already discussed. They are going to reduce the mortality as well as morbidity. You already know that ARBs reduce morbidity, and the sacubitril will be causing a mortality reduction. So that is a very important thing. Now moving on to talk about the nesritide. This nesritide is a GIT peptidase. Okay, remember this nesritide, if you are going to give by oral route, what happens is they will be broken down by your GIT peptides. Remember, they will be broken down by your GIT peptide. Therefore, what you are going to do is you are going to give always by IV route. You are not going to give it by the oral route. You are going to give nesritide only by IV route. So this is a drug of choice in case of congestive heart failure and acute decompensated heart failure. What are the side effects? It can cause hypotension, and this can cause reduction in the renal perfusion. Very important. Now you have other drug called as vasopeptidase inhibitor. This vasopeptidase inhibitor, they are going to inhibit. Okay, what it does is it is going to inhibit your ACE. Okay, it is going to inhibit your ACE. It is also going to inhibit your NEP. Instead of giving a separate drug for ACE inhibitors and your sacubitril, there's a single drug that is going to break down all your vasopeptidase. That is going to be your omapatrilat. So the one doctor would have thought, எதுக்கு நம்ம ரெண்டு drug கொடுக்கணும், let's make it as a single drug. So அதோட discovery தான் omopatrilat. Omopatrilat is going to inhibit both your AT1 angiotensin converting enzyme as well as your NEP. So what is NEP? Neprilysin. Okay, omopatrilat. So this omopatrilat, when you're going to give, they are going to prevent the cardiac remodeling. But the problem here is there is going to be excessive amount of bradykinin that is going to be present. Both this brain natriuretic peptide breakdown or brain natriuretic peptide neprilysin, they are going to be involved in the bradykinin metabolism. ACE was also going to involve in bradykinin metabolism. So when you're going to give them together, they are going to cause angioedema. So a very important thing, even if you're going to give a ACE inhibitor separately like enalapril or your sacubitril, when you're going to give these two drugs together also, there is going to be an increased angioedema and neovascularization. This is a point I want you all to note it down. Now coming to the angina. What is angina? Angina is nothing but when there is going to be a chest pain due to myocardial ischemia. Chest pain due to myocardial ischemia is called as angina. Okay, clear? Now there is going to be decrease in the ST. Okay, there is going to be decrease in the ST. That is going to be, what is ST? I told you, repolarization. So இங்க என்ன ஆகும்னா, there is going to be a ST ல changes ஏற்படும். Either there can be increase in the ST or there can be decrease in the ST. Okay, so we have started around 2:30 and now it is time is 4:30. I'll give you 10 minutes break. I'll give you 10 minutes break or 5 minutes break. I'll give you at around 4:35. We will start with again. 4:35 we will start with again. I'll give you 5 minutes break. Don't log off or don't do anything. Just keep it aside. Just keep your note aside. You can take some water and come back around. I'll give you some 5 minutes. Around we will start by around your 4:35. We will start again. So welcome back. So till before the break, we were actually seeing about the first line, or that is going to be your class 1, class 2, and class 4 of your anti-arrhythmia drugs. And we have also discussed about atrial fibrillation and your paroxysmal supraventricular tachycardia. We have discussed about these three important drugs which we have seen. Now what we are going to do is we are going to discuss about the next set of drugs. That is going to be, what is the next set of drugs which we are going to see? We are going to see the remaining only one class is left with. We are going to see the next class, that is going to be your class 3 group of antiarrhythmias. So what is your class 3? Class 3 is going to be very similar. Class 3 is going to be, remember, it is going to be very similar to that of your class 1A. How what happens in class 1A? There is going to be both sodium channel inhibition and potassium channel inhibition, right? But in your class 3, what we are going to do is we are not going to have the sodium channel. We are going to just have only the potassium channel blocker. So in class 1A, I'm just going back. In class 1A, you add both sodium channel as well as potassium channel, which is getting inhibited. But here what happens in your class 4, you're going to class 3, you're going to have only potassium channel blockers and there is no sodium channel blockers. If there is no potassium channel blocker, no sodium channel blocker and only potassium channel blocker, what happens? There is no change in your phase 0. Phase 0 remains the same. But what happens? The phase 2, which is going to be there, phase 3, which is going to be there, phase tachycardia. Earlier it was again lignocaine, but since lignocaine caused asystole, they moved on to amiodarone. And finally, ACLS protocol, buddy, it is a preferred antiarrhythmic drug than your lignocaine. Now, moving on to talk about the entire antiarrhythmic drugs, whichever we discussed till now. Can you just recall? So we had a separate paper, right, where we wrote like this. Can you write it? Can you check whether you have written everything? P stands for procainamide, D stands for disisopyrimidine, and Q stands for quinidine, L stands for lignocaine or lidocaine, M stands for mexiletine, F stands for flecainide, P stands for propofenone, and T stands for tocainide, and P stands for propranolol, E stands for esmolol, A stands for amiodarone, D stands for dofetilide, S stands for sotalol, I stands for ibutylide, D stands for dondron, and you're going to have your dirty vehicle diltiazem and verapamil. These are the drugs which are going to be acting as these are the drugs which are going to act as anti-arrhythmic drugs. If you want, you can take a screenshot. So this is how we are going to remember the entire anti-arrhythmic drug. You are not also going to change the order. Now you can tell the first few are going to be, first three are going to be your first it's going to be your number one sodium 1A blocker. Then you're going to have 1B class. Then you have 1C class, then 2, then 3, then 4. It is going to be in the order, so you can remember it in the order. Okay, now moving on to talk about the last part, antihypertensive drugs, which we will be completing in the next 15 minutes. Antihypertensive drugs, remember, everything is already covered. So we have covered all the actions or all the mechanism of action of every single drug. Now you are just going to correlate, you are going to compile everything and put it into a one single antihypertensive drug. Why you want, what is the mechanism of action of antihypertensive drug? Either they have to reduce the systemic vascular resistance. How they are going to decrease the systemic vascular resistance? They have to decrease the systemic vascular resistance by vasodilators, or you can decrease the cardiac output. Okay, by decreasing the cardiac output, we can decrease the total amount of blood pressure. Okay, so what are the things you're going to give? So remember the diuretics. The first thing you're going to give is diuretics, thiazide diuretic more than furosemide. Why? We have discussed already. Then RAS inhibitor. What is the RAS inhibitor? We are going to give AC inhibitor, ARB, spironolactone. And most important is going to be sympathetic system inhibitor. What are the sympathetic system inhibitor or sympatholytics? You have number one, you can actually go for the alpha 2 blocker. Clonidines can be given, or you can go for beta 1 blockers. You can go for beta 1 blockers. What is the use of beta 1 blockers? Beta 1 blockers are going to reduce the heart rate, that it is going to reduce the cardiac output, that is going to reduce the BP. Okay, beta 2 is going to be causing a clonidine. Beta 2 is going to cause smooth muscle vasodilation. If it is we are going to block your alpha 2, it is going to cause smooth muscle vasodilation, and that is also going to be acting. Okay, so let's see one by one what are the drugs which are going to be there. Number one, hexamethonium. What is hexamethonium? This is going to be a drug given in antihypertensive as a hypertensive crisis. So this is used in the neuromuscular blocker. Remember, and you can also inhibit the noradrenaline production. How do you produce? Noradrenaline is produced tyrosine. You have something called as tyrosine. That tyrosine gets converted to a dopa. So they are going to convert into a dopamine. So what happens? This tyrosine to dopa is going to be converted by tyrosine hydroxylase. You have a drug called as metyrosine. Metyrosine, what it does is, it is going to inhibit. This metyrosine is going to inhibit your TH, tyrosine hydroxylase. That is how you are going to inhibit the formation of adrenaline, noradrenaline. They are the sympathetic drugs. So that is going to be prevented from formation. And you have something called as reserpine. What is this reserpine? Is your dopamine. Okay, actually they will be forming into a vesicles. This dopamine has to be formed into vesicles by a receptor. What is the receptor that is going to be allowing the formation of dopamine into vesicles? Anyone knows? Anyone knows? That is going to be your VMAT. That is going to be a VMAT, vesicular monoamine transporter. Now you have some drug which is going to inhibit this vesicular monoamine transporter. What are the drugs that are going to inhibit the vesicular monoamine transporter? That is going to be your reserpine. Reserpine is going to inhibit the vesicular monoamine transporter. Am I not audible? Am I audible? Anyone? I think Pandi is telling I'm not audible. Can someone respond if I'm audible or not? Can someone respond me in the chat box if I'm audible or not? Yes, right? Okay, okay. I think he is having some problem. Kindly check. Okay, now it's audible. Fine. So you're going to have a reserpine that is going to block your vesicular monoamine transporter. Now you are going to have dopamine inside. This dopamine gets converted into noradrenaline. So inside your vesicles, the dopamine gets converted into noradrenaline. Now what happens? You are going to have your synapse. In the synapse, your noradrenaline is released. This releasing of noradrenaline into the synapse is going to be prevented by the drug called as guanethidine. So guanethidine is a drug. Guanethidine is a drug that is going to prevent the release of noradrenaline into the synapse. So you have three drugs: metyrosine, reserpine, guanethidine. Hope you all can now tell what are the mechanism of action of reserpine, guanethidine, and your my metyrosine. Clear, right? Next we are going to discuss about the so vasodilators. So what are the vasodilators? We already saw nitrates, which is going to cause venous dilatation. Then there are some drugs which causes arterial dilatation. What are the drugs that cause arterial dilatation? Dihydropyridine. What are dihydropyridine? All your nifedipine. So all your dipine group of drugs, calcium channel blockers, comes under dihydropyridine. Next, you have phenaldopam. What is phenaldopam? It is given in the hypertensive crisis. Next, potassium channel opener. This potassium channel opener is going to cause hyperpolarization. And once it is going to cause hyperpolarization, what happens is there is going to be a inhibition of contraction leading to relaxation of the smooth muscles of your vascular smooth muscles. Now what happens? Because of this, what are the drugs you have? Number one, minoxidil. Minoxidil is nothing but, if most of them nowadays, I'm not sure how many of you here are using. So most of them who are having an air fall, when you're going to go to your dermatologist present in your medical college, what she will be prescribing you is this one so-called minoxidil. Minoxidil 5% is commonly used topical application for alopecia. And for hypertension, we use minoxidil IV in hypertensive crisis. But the problem with minoxidil is they have hirsutism. They can cause hirsutism. Okay, now coming to the diazoxide. Diazoxide is also again used in hypertension crisis. But the problem is they decrease the insulin, leading to hyperglycemia. So it is the treatment of choice in insulinoma. In insulinoma, there is an increase in the insulin. So you are going to give this diazoxide. And now the third one is hydralazine. Can you tell me what is the mechanism by which the hydralazine gets metabolized? Can someone put in the chat box? The mechanism by which hydralazine is metabolized. The mechanism by which hydralazine is metabolized. Can you tell me the mechanism by which hydralazine is metabolized? Anyone? For the past 2 days, I have told repeatedly for 5 to 6 times. Acetylation. Very good, Magendran. So what are the drugs that are going to be metabolized by acetylation? SHIP. S stands for sulfur drug. And H stands for hydralazine. I stands for isoniazide. And the last one, P stands for procainamide. So all these drugs are going to be causing a SLE. So drug-induced SLE or causes one in the SHIP drugs. Clear, right? Now coming towards the hydralazine, they are potassium channel openers. They don't have no donor. So SLE, it is going to cause drug-induced SLE, where all you're going to use in antihypertension, you're going to use. And these drugs are also used. Hydralazine is used along with the you're going to also use with the dinitrate. You're going to also use with the dinitrate. So what is a drug when you're going to use with dihydrate called as Bildil? You're going to call this as Bildil. Do you remember where we saw this Bildil? Anyone? Where did we saw this Bildil? We saw in the nitrates when we are discussing about the angina. When I was discussing about angina, I was telling, right? So you're going to have your isosorbide dinitrate. So this isosorbide dinitrate, when you're going to add with your hydralazine, isosorbide dinitrate is going to be a venodilator, and your hydralazine is going to be a arteriodilator. Combining both is called as bidilator. We call it as biodilator, that is called as Bildil. Okay, next is a mixed sodium nitroprusside. Mixed sodium nitroprusside, they are going to be releasing your nitric oxide. This is going to cause increase in cyclic GMP, and you know how it is going to be causing a relaxation of smooth muscles. Now, you can give this IV infusion. What happens when you're going to give IV infusion? It is going to be helping you to reduce your diastolic BP, and this is also given in case of acute heart failure. Side effect is it can lead to hypotension, and when you increase the dose, it is going to cause cyanide toxicity. So what is a drug of choice in cyanide toxicity? So hydroxycobalamin is a drug of choice in case of cyanide toxicity. Now coming to the hypertensive emergency. So when you are going to experience a case with hypertensive emergency, how you are going to approach that patient? That's all you want to need, because now you know all the mechanism of the drug. Now you have to understand how you are going to see a patient who is going to come with hypertensive emergency. If the systolic BP is more than 180 or diastolic BP is more than 120, okay, you are going to call it as hypertensive emergency. Okay, and what hypertensive urgency? You're going to call it as hypertensive urgency. You are just going to give oral drug. Okay, you're just going to give oral drug. But if the patient comes to you with systolic BP more than 180, diastolic BP more than 120, but along with organ damage, now the patient is going to have something called as organ damage. Now you're going to classify it as a hypertensive emergency. Or if the patient is going to have more than 180 bar 120 with acute MI, or when the patient is going to have a hypertension with stroke, okay, then what you're going to give is, before classifying, even before thinking it is a hypertensive emergency, you're going to start with a trinitroglycerin, and now you're going to start with the hypertensive emergency treatment. So what is the hypertensive emergency treatment? Number one, calcium channel blockers. What calcium channel blockers you will be giving? Writing, you have to write 9 points. So there are totally 9 drugs which you will be giving in the hypertensive emergency as a IV route, not as a oral route. What are the drugs? Nicardipine or clevidipine. So that is your calcium channel blockers. Then you have to go for beta blockers. What are the beta blockers? Labetalol, esmolol. Both are given as a beta blocker. Then you are going to have a nitroprusside. Then you are going to have your phenaldopam. So phenaldopam we are going to use in the hypertensive crisis. We told already, right? Then you have diazoxide hydralazine. Then you are going to have furosemide. Then enalaprilat, and you have hexamethiopium, and you have phentolamine. These drugs are going to be used as a hypertensive emergency cases. I'll give you time, kindly copy down. Number 1, calcium channel blockers, nicardipine and your clevidipine. Number 2, beta blockers, labetalol, esmolol. Number 3, you're going to have a nitroprusside. Number 4, phenaldopam. Number 5, diazoxide. Number 6, hydralazine. Number 7, furosemide. Number 8, enalaprilat. Number 9, hexamethonium. And number 10 is going to be phentolamine. Clear, right? So furosemide, especially when the patient is going to have hypertension more than 180 bar 120, plus when the patient has a acute renal failure, the only drug of choice is going to be a furosemide, nothing else. Okay, when acute renal failure patient with hypertension crisis, you're going to come with your OPD, you're going to give furosemide. That's all. Now coming to the pregnancy-induced hypertension. Pregnancy-induced hypertension, mild to moderate on the, you're going to go for a labetalol, methyldopa, or dihydropyridines. What are the dihydropyridines? Can you tell me in the chat box? What is dihydropyridines? Example of dihydropyridines. Can you just name in the chat box? What are the example of dihydropyridines? Can you just name dihydropyridines example? Come on, guys. Come on, guys. Very nifedipine, amlodipine. Idella dihydropyridines. Sure? Are they going to be a dihydropyridines? Very good. So what is going to be non-dihydropyridines? Can you tell me non-dihydropyridines? Excellent, Magendran. It is verapamil. So dihydropyridines is going to be a nifedipine, amlodipine, and non-dihydropyridine, they are going to be your, as you guys told, it is verapamil, diltiazem. Very good. Now coming back to talk about the hypertensive crisis. So in hypertensive crisis, in the pregnancy-induced hypertension, you have to go for your labetalol, hydralazine, or dihydropyridine. And what is in eclampsia? In eclampsia, you're going to go for magnesium sulfate, Pichat's regimen. You will be reading that in your obstetric and gynecology later in your final year. But now remember, in eclampsia, the drug of choice is going to be a magnesium sulfate. Now coming to the contraindication, ACE inhibitors, ARB, you should never use because they can cause teratogenicity. Nitroprusside, they will lead to cyanide toxicity. So you're not going to give. Atenolol, you're not going to give because they cause low birth weight in the baby. Thiazide diuretic, it will be causing hypoperfusion. Now, how you're going to select the antihypertension? Depending upon the comorbidity, you're going to select the antihypertensive drug. For example, when there is hypertension with diabetic mellitus, chronic renal failure, congestive heart disease, then you're going to go for ACE inhibitors or ARB. Clear? Next, glaucoma, hyperthyroidism, migraine, stress, anxiety, go for beta blockers. Third, if the patient is going to have a benign prostate hypertrophy, go for prazosin. If the patient is going to have hypertension after a scorpion bite, remember scorpion bite, you are going to go for the alpha 1, that is going to be a prazosin. When the patient comes to you with a pheochromocytoma, go for alpha 1, alpha 2 blocker. And when the patient is going to be having a diabetes, hypertension, bilateral renal artery stenosis, when this is going to be a case, diabetes, hypertension, and your bilateral renal stenosis, the answer is going to be amlodipine. Never remember, amlodipine is a drug of choice when the patient is going to have hypertension, diabetic, and a history of your bilateral renal artery stenosis. Now coming to the pulmonary artery hypertension, when there is going to be fall in the pulmonary artery pressure after inhaling nitrous oxide. That is going to be a very important point. Okay, so what you are going to do in pulmonary artery hypertension, start with a vasodilator test. What is vasodilator test? You are going to inhale nitric oxide. After the nitric oxide, if there is a fall in the pulmonary artery pressure, it is going to be positive. You are going to give dihydropyridine like nifedipine, amlodipine. If the vasodilator test comes to be negative, then you are going to classify into grade 1, grade 2, grade 3 pulmonary hypertension. So what is a drug of choice? Endothelin inactivator. What is endothelin inactivator? Ambrisentan and your mesisentan, and you're going to have bosentan. So these are the three drugs, endothelial inhibitors. Bosentan, ambrisentan, mesisentan. These are the three drugs. They are going to be called as endothelial inhibitor. Then you are going to have PDE5 inhibitor. What are PDE5 inhibitor? Sildenafil, tadalafil, and avenafil. So these are the PDE5 inhibitor. And severe case you go for prostacyclin I2, that is PGI2 you will be going. Now coming to the oral drug, you have selexipag. Selexipag is a PG12 receptor agonist. So PGI2 receptor agonist. So you can go for that. What are the drugs? You have your ipoprostenol, treprostinil, elioprost. So what are the three drugs? Ipoprostenol, treprostinil, elioprost. So epoprostenol is given as IV pump, treprostinil is given in the longer subcutaneous route, elioprost is given in the inhaled route. Now finally coming to your PDE5, phosphodiesterase 5 inhibitor. So you have sildenafil, it's going to be causing optic neuropathy, very important. And PDE6 inhibitor, it will be affecting your retina and causes blue-green differentiation, color blindness. Okay, then you have tadalafil. That's why sildenafil is also used in the erectile dysfunction, Viagra tablet. Okay, so adana Viagra tablet will be leading to what? Color blindness. Now coming towards the next one, tadalafil. Tadalafil is a long-acting drug, 36 to 40 hours. It's going to be PDE6 inhibitor. Okay, then coming towards, it does not have PDE6 inhibitor, therefore there is no color blindness. There is no color blindness. Then the third one is going to be your avenafil. Avenafil is a fast-acting drug. Never use PDE5 inhibitors with nitrates because both are going to cause vasodilation and it is going to cause severe hypotension. With this, we are completing the cardiovascular diseases. I'm very sorry, I have my OPD, I have a case which will be there. I have to go and see. So what I will do is I'll come back at 9:30 and let's start discussing the only chapter left out. That is going to be your GIT. Okay, only chapter that is left out is GIT. So let's start with the GIT drugs by around 9:30. So 9:30 to 10:30, let's have just 1 hour. In the 1 hour, we will try to complete all the drugs which are present in the GIT. With today, we will be completing the entire pharmacology. Okay, thank you so much. Good evening, all. So let's continue with the discussion on peptic ulcer. Okay, so till now we have completed cardiovascular diseases, we have completed the central nervous system, and we have completed the renal, and the only system that is left with is going to be your GIT. So in GIT, we are going to discuss on peptic ulcer. We are going to discuss on the topic antacids, then vomiting, so antiemetic group of drugs. Then we will talk about the IBD. So that is going to be inflammatory bowel disease. A very short topic. After this short topic, what I will try to do is I'll try to cover adrenergic system first, and I will try to cover cholinergic if time permits. Otherwise, actually this adrenergic cholinergic is already completed as far as my in the YouTube I have already taken a session. But then what I thought is, okay, if you want me to cover again, I'll be ready to cover it. But the only thing is we will see, depending upon the timing today, we will see whether if we can cover or not, because we can't extend beyond 11:30. So accordingly, we will be taking the session. Clear, right? So let me start with the GIT drugs. So the first thing in the GIT is going to be your peptic ulcer. Okay, let me see those who have joined. Is my screen visible and am I audible? Can someone confirm whether my screen is visible and whether I'm audible? My voice is clear, right? Can someone put in the chat box if my voice is clear? Afif and others, can you just confirm if my voice is clear and my screen is visible, right? So shall I continue? Shall I continue, guys? Okay, so let me start with this peptic ulcer. Remember, peptic ulcer. Okay, what happens exactly? In your gastric mucosa, you're going to have a gland. I already told about this gland that is going to be in the influence of your histamine blocker. Okay, they are going to be under the influence of H2. H2. Okay, so what happens? This is going to be your H2, that is going to be a histamine. So you're going to have you're going to have histamine H2 receptors. You're going to have a M, that is going to be muscarinic receptors. These two receptors are present in your gastric gland. So what happens whenever there is going to be stimulation of your H2 or stimulation of your M? What happens? There is going to be a H plus K plus ATPase. This H plus K plus ATPase will be secreting H plus outside into your mucosa. It is going to be secreted into your mucosa. From your mucosa, it is going to be secreting out. So you have a gastric glands along the mucosa of your GIT, especially in your stomach. That is going to be a parietal cells. So in your parietal cells, you're going to have this gland which is going to secrete H plus. So that is controlled by two persons, H2 receptor and your muscarinic receptors. So which one it is going to control? H plus, K plus, ATPase. Now you have three options. Either you can inhibit the H2 receptors, okay, or you can inhibit the M receptor, or you can inhibit the H plus K plus ATPase. These are the three mechanisms by which we are going to reduce the gastric secretion in our stomach mucosa. So what are the three steps? Number one, you are going to block your H2. Number two, you are going to block M. Number three, you are going to block your H plus K plus ATPase. First one is your H2. How you are going to block H2? By giving drugs like H2 blockers. We have already seen these H2 blockers. I'm again repeating. It is cimetidine, ranitidine, etc. Cimetidine is not used nowadays because it had an anti-androgenic effect. So it leads to gynecomastia, galactorrhea, dizziness, and a potent cytochrome P inhibitor. Therefore, we are not using this cimetidine nowadays. Next, we have is a ranitidine. This ranitidine is actually you are not going to see all these side effects which we add in your cimetidine, like your galactorrhea, dizziness, anti-androgenic action, and potent cytochrome P inhibitor. These actions are not seen in your ranitidine. Plus, this ranitidine is also going to be used in the H2 blocker. Commonly, we use under the trade name Rantac. Under the trade name Rantac. Okay, so but what happened is you would have all seen a notice from our 2020 from our Indian drug regulator that some NMDA contamination occurred in the tablet and that led to cancer. And many people what they thought is ranitidine led to cancer. No, ranitidine is not leading to cancer. According to the 2020 Drug Regulatory Committee notice, what they told is NMDA has been contaminated in your ranitidine and that led to cancer. It is not ranitidine that caused cancer. So now the Drug Regulatory Panel, what they told us, they are keeping a very strict, keen observation that NMDA is not contaminated in the ranitidine. Clear, right? The third one is going to be a famotidine. Famotidine is going to be again a very highly potent inhibitor of your H2 receptor. And you have lafutidine. This has no release, absolutely no. Okay, it's going to be absolutely causing a nitric oxide release, no release. Nitric oxide is going to be released by your lafutidine in addition to that of your anti-secretory activity. Second one is an anti-muscarinic agent, M1. So anti-muscarinic agent, they are going to be piperazepine and telanzepine. Now this is not used. Pyrazepine, telanzepine is not used commonly. Now coming to the next one, that is proton pump inhibitor. So I told you three mechanisms. First is a H2 blocker. Second is going to be your M blocker, that is going to be muscarinic blocker. The third one is going to be your proton pump inhibitor. Which one we are going to inhibit? H plus K plus ATPase. Most potent acid suppressor. So they are going to be the drug of choice in peptic ulcer disease, in GERD and Zollinger-Ellison syndrome. Can you tell me what is the drug I told you that is also going to be helping in the reduction of the GERD, a prokinetic drug which is used in combination with that of your proton pump inhibitor? Can you tell me? I told you a drug which is used in combination with your pantoprazole, okay, which is going to be a prokinetic drug used in GERD. Can someone name it in the chat box, which I told in the previous session when I am discussing autocoids? Anyone? Do you remember? What is the drug we have that is going to be acting, that is going to supplement your pantoprazole along with your pantoprazole? Pan-D. Can you tell me what is the content of Pan-D? Can you tell me what is the contents of Pan-D? Pan-D is a commonly given drug which is going to be given in case of a peptic ulcer disease as well as your GERD. Can you tell me what is the contents of Pan-D, pantoprazole as well as what is the other one? Along with pantoprazole, what you are going to have? Along with pantoprazole, anyone? Domperidone, excellent. So domperidone is another drug. What is domperidone? Can someone tell me what is domperidone? What it is going to block? Domperidone. Domperidone is going to be a, what is going to be a domperidone mechanism of action? Can someone tell me what is the mechanism of action of domperidone? It is going to block your dopamine 2 receptor, D2 receptor. It is going to be a D2 antagonist. So we will be always using pantoprazole and domperidone when it is going to be a GERD and we have Zollinger-Ellison syndrome. Now coming to the mechanism of action of your pantoprazole or any prazole group of drugs, that is going to be a proton pump inhibitor, that is going to be H plus K plus ATPase. They will be causing an irreversible inhibition. Duration of action is going to be 48 hours. There will be a suppression of acid secretion. Okay, they will be resuming to secrete acid after 3 to 4 days after stopping the run. So any hit and run drug. So whenever they are going to ask you hit and run drug, that is going to be, example is going to be your pantoprazole. So you are going to take early in the morning in the empty stomach you should take, that is before food. What are the side effects? Number one, there is going to be decreased absorption of calcium, iron, magnesium. There is going to be a decreased absorption of calcium, iron and magnesium. So whenever there is going to be decreased absorption of calcium, it leads to hypocalcemia and that leads to parathyroid hormone activation and causing osteoporosis and fracture. So this is called as hypocalcemic fracture. Number two is going to be iron. So iron is going to lead to iron deficiency anemia. When there is a reduced magnesium absorption, it leads to hypomagnesemia. Now coming to whenever there is going to be this is going to also cause increase in the infection. You all know that the acid is required for the for destroying all the pathogens that are present in that is going to suppress your pathogens that are going to be present in the inherently in your gastric mucosa. Now what you're going to do, you're going to suppress the gastric acid. If you're going to suppress the gastric acid, it will lead to two important conditions. Number one, Clostridium difficile. This Clostridium difficile is going to give a toxin A or toxin B. This toxin A is very, very dangerous. They lead to a disease called as, can someone tell me? Can someone tell me what is the disease it leads to? Clostridium difficile. Clostridium difficile leads to what? Clostridium difficile leads to pseudomembranous colitis. I discussed this also when I am discussing in the antimicrobial. So whenever you're going to give excessive antibacterials or your antibiotics, that also leads to Clostridium difficile. So it leads to pseudomembranous colitis. Pseudomembranous colitis. Okay, and then it is also going to lead to hospital acquired pneumonia. Rarely they can cause acute kidney injury and dementia, but very rarely there are only 0.001 incidents. That also I want you all to remember. That's why I've just written it. And it leads to gynecomastia, a very similar problem which we had with the cimetidine, even your pantoprazole. Okay, now clopidogrel, when I told you this when I'm taking clopidogrel, antiplatelet drugs. So clopidogrel, when you're going to take it omeprazole, what happens is this omeprazole or all your prazole group of drugs, they are inhibitors of cytochrome P2C19. So all your clopidogrel, platelet and all your pro drugs, they require this 2C19 drug, which will be like metabolizing these drugs, and it is going to activate the drug. Now, if you are going to give this PPI, proton pump inhibitor, what happens? It is going to inhibit this cytochrome P2C19. So this clopidogrel doesn't get activated. So if the clopidogrel doesn't get activated, what is going to be the problem you're going to face? When the clopidogrel doesn't get activated, that is going to lead to failure of antiplatelet treatment. So you should never give clopidogrel and your omeprazole or lansoprazole or pantoprazole group of drugs. Remember, pantoprazole has a minimal inhibition of cytochrome P compared to that of rabiprazole, compared to that of your omeprazole and lansoprazole. This is a very important point. Now coming to, okay, this is your peptic ulcer. I told you the first action of peptic ulcer is anti-secretory. Now we have reduced the acid secretion. What is the second thing which we can do? We can give antacids. So already secreted acids will be there. What we are going to do? We are going to give antacids, and this antacids will help in the neutralization of acid, chemical neutralization of acid. What is the side effect? Side effect is rebound activity. What is the use? A rapid symptom relief. It is going to lead to rapid symptom relief. What is going to be the drug you're going to use? Either magnesium hydroxide or trisilicate, magnesium trisilicate. Have you ever seen this Gelusil? Okay, antacids. There are many antacids available. Gelusil is one such antacid. So everything is going to just neutralize the acid. You would have seen in the ad itself what they will be telling. You can just take the antacid. What happens? It is going to enter into your stomach. It is going to line your gastric mucosa, and it is going to fight with. There will be like a fighting acid and your Gelusil, and it will destroy your acid. Like this only you have an advertisement, right? So same way, magnesium hydroxide, magnesium trisilicate, they are going to act as antacids. But the problem is going to be, they are going to be fast acting and they can cause diarrhea. So what happened is they found a new drug that is going to be your aluminum hydroxide. This aluminum hydroxide, they are going to be slow acting, but they can cause constipation. So what happened? Now we found a new drug called as magnesium aldrate. Magnesium is also there, aluminum also there. So diarrhea, constipation. It is going to neutralize the effect of diarrhea and constipation. You have a homeostasis between the drugs. So you're going to use a magnesium plus aluminum salt combination that is called as your megaldrate. You will be using a drug called as megaldrate. So in pregnancy, antacids are safer to use than your H2 blocker, than your PPI, pantoprazole or lansoprazole, etc. So remember, so antacids are the drug of choice. Second choice is going to be a rantacid. That okay, only then you can go for your PPI. Clear? Now coming to the gastroprotective. So you're going to have something called as sucralfate. So this many alcoholic patient, when they are going to come with the GERT complaint, so the drug you're going to give is a sucralfate. So it is a oral syrup. What it is going to have a pH less than 4. So what you're going to do, this is going to cause a polymerization. In the pH less than 4, they get polymerization and they're going to stick on the ulcer base. They're going to stick on the ulcer base. Ulcer base labde ottikkum. And side effect is hypophosphatemia. This causes hypophosphatemia. So antacid, H2 inhibitor or PPI. Edu kudthal enna pannuna? They will be increasing the pH level. So and you have to remember that you should never give sucralfate along with antacids. Why? Because sucralfate acts only in the presence of acidic environment. You're going to give antacid also, like your pan D, you're going to take, and immediately you're going to take a sucralfate. What is the use? So remember, there will be a failure of sucralfate when you're going to eat, when you're going to take it after consuming antacid or H2 inhibitor or your PPI. Therefore, only after 2 hours of consumption of antacids or H2 inhibitor or PPI, you have to take this sucralfate. Otherwise, it will be a failure. It is not going to have any use of taking sucralfate. Now, moving on to talk about the misoprostol. Now, moving on to talk about the misoprostol. Remember, guys, misoprostol. Okay, what is the importance of misoprostol? So, have you read anywhere else misoprostol? Can you recall and tell me? Yes, it is one of the drug for abortion. So misoprostol is a NSAID induced ulcer. You're going to take misoprostol is prostaglandin E1. So they are going to increase the blood flow, they are going to increase the mucus production, and they are going to cause decrease in the acid secretion. So misoprostol is going to be given in case of NSAID induced ulcer. So drug of choice is going to be, first you will give PPI only, but most specific what you have to give, misoprostol. What are the side effects of misoprostol? Nausea, vomiting, cramps, and pain. Inflammatory bowel disease is also one of the important feature which you have to understand. Next is going to be abortion. So they are going to be called teratogenic Mobius gene syndrome. Remember, what is Mobius gene syndrome? Because of your misoprostol tablet, but the baby is not aborted. Instead, what happened? This misoprostol tablet caused a teratogenic effect, and it led to 6th and 7th nerve palsy, and it caused Mobius gene syndrome. Okay, what is your bismuth? Third drug is going to be bismuth. First, we saw the sucralfate. Second, we saw as misoprostol. And the third one is going to be sucralfate. Again, sucralfate is going to increase the mucus production. They are going to bind to the mucosa, and they cause detachment of H. pylori, a very, very important H. pylori infection. So bismuth subsalicylate is a drug of choice in the traveler's diarrhea. So the side effect is going to be black tongue. Okay, now coming to the colloidal bismuth sulfate. When you will give a colloidal bismuth sulfate in a peptic ulcer disease, remember, bismuth subsalicylate is given in traveler's diarrhea. Colloidal bismuth sulfate is given in case of a peptic ulcer disease. Now, what is the treatment for your pylori, H. pylori drug? Remember, you have something called as triple therapy. You have something called as quadruple therapy. What is triple therapy? Remember, CAMP. What is CAMP in triple therapy? You are going to give clarithromycin or amoxicillin. You are going to give either clarithromycin or amoxicillin, along with that metronidazole and proton pump inhibitor. Metronidazole and proton pump inhibitor. That is going to be a omeprazole or your pantoprazole or your lansoprazole, any prazole group of drugs. Okay, what is done in the quadruple therapy? In quadruple therapy, you're going to give tetracycline. Instead of clarithromycin or amoxicillin, you're going to go for a tetracycline. Along with tetracycline, you go for omeprazole, metronidazole, and bismuth group of drugs. Clear, right? So now coming to the last one, that is going to be antiemetic drug. So I already discussed about the antiemetic drug. You have a vomiting center. So vomiting center oda edu connect aayirukna, GIT connect aayirukku. See, whenever your vomiting center is going to be triggered by your CTZ. What are the drugs that are present in the what are the receptors that are present in the CTZ? You're going to have D2 receptor, you're going to have NK1 receptor, you have a 5-HT3 receptor. Can you name some of the NK1 inhibitor or antagonist? Can someone name at least the last epinome which we will be giving for the drug? Can you tell me? NK1 inhibitors or NK1 antagonist. I'll see how many of you remember. Afif attended morning session. Can you tell? Very good. Aripipitrant. Okay, very good. So that is going to be your NK1 inhibitor. Very good, excellent. And you have your D2 inhibitor and your 5-HT3 minus in 5-HT3 inhibitor. These are the drugs which are going to be these are the receptors that are present in the CTZ, and you're going to this CTZ is going to trigger your vomit center. And apart from that, you also have a trigger from your vestibular apparatus. Your vestibular apparatus is going to have a muscarine receptor. This muscarine receptor, again, it is going to have a vomit center connection. Muscarine receptor and H1. Similarly, you're going to have anything when you're going to eat that is unpleasant. Okay, what happens? Your GIT is connected with a vomiting center. What is the receptor present in GIT? That is going to be 5-HT3. So now the first drug which you're going to see is what are the serotonin 3 receptor inhibitor. Serotonin 3 receptor inhibitor are ondansetron, granisertone, palinosertone, all your sertone group of drugs. Among them, palinosertone is going to be a most potent drug. Okay, they are the drug of choice in post-operative vomiting, radiation and vomiting, and your chemotherapy-induced nausea, vomiting. Clear, right? So what is the side effect? There is going to be raise in the QT interval. So there is going to be a minimum is there in your palinositron and maximum is going to be there in dolasetron. Okay, now I have already talked about this your chemotherapy-induced nausea, vomiting. If it is going to be in acute phase within hour, you are going to go for 5-HT3 inhibitor plus dexamethasone, or 5-HT3 inhibitor. What you are going to give? You are going to give palinosartan. So palinosartan and your dexamethasone is given in the acute phase within 1 hour of chemotherapy. If it is going to be a delayed phase, you go for 5-HT3 inhibitor, dexamethasone, NK1 inhibitor. 5-HT3 inhibitor, you go for palinosartan and dexamethasone. And what is the drug you are going to give for NK1 inhibitor? That is going to be your aprepitant, rolapitant, and natopitant. Aprepitant, rolapitant, and natopitant. So Afif, kindly note down the spelling. So next time, please don't make an error in the spelling also. Now you remember what is a drug. Next time, even the spelling must not be wrong when you are going to attempting to give a correct answer. Okay, so now we are going to move towards the antiemetic drug. This antiemetic drug is going to be decreasing the vomiting sensation, and your prokinetic drug. Prokinetic drug is going to increase the GI motility. Now coming to the first drug, metoclopramide. Metoclopramide is going to be there, and domperidone is there. Metoclopramide, what it does is, it is going to act as antiemetic drug by inhibiting your D2 in the CTZ and 5-HT3 antagonist. And it is whereas your domperidone is going to act as a your D2 inhibitor on your CTZ. Now coming towards your prokinetics, you have D2 inhibitor on GIT, 5-HT4 inhibitor on GIT, and decrease the acetylcholine release in GIT. இது வந்து வெறும் D2 inhibitor in GIT தான் domperidone. Now coming to the blood-brain barrier, you know that domperidone cannot cross your blood-brain barrier, whereas metoclopramide can cross blood-brain barrier, and that can lead to extrapyramidal symptom. I'm not going to explain the extrapyramidal symptom. What is the drug of choice for the extrapyramidal symptom? It is going to be a benzexol. Benzexol is a drug of choice in case of extrapyramidal symptom. That is a central anticholinergic. The alternate drug is going to be a benztrophin. Okay, then cannabinoids. Cannabinoids, what are the cannabinoids? You know, dronabinol and nabilone. Remember, nabilone is a synthetic drug which is used nowadays, and it is used as antiemetic, and it is used mainly in the HIV and cancer. In HIV and cancer associated nausea, vomiting, we will be giving, and this cannabidiol can be used as a anti-seizure drug also. Now coming to the morning sickness, you go for doxylamine. It's an anti-H1 plus or minus vitamin B6. Now finally we are going to move to the next one, that is going to be anti-diarrhea agent. So diarrhea nale enna agudhu? Because of the increased motility. So nama vomiting la we wanted to increase the motility so that forward movement is there, but in anti-diarrheal we wanted to reduce the motility. How we are going to reduce the motility? By peripheral mu opioid agonist, by peripheral mu opioid receptor agonist. So what are the peripheral mu opioid receptor agonists? You have your diphenoxylate and loperamide. Loperamide is an important drug which we give now and then in the OPD. So this is going to does not cross your blood-brain barrier, and they are going to be anticholinergic in nature. They do not have atropine. They do not have any atropine. Okay, wow. So now coming towards the phenyloxylate. Phenyloxylate will be causing a blood-brain barrier also. So therefore you will have a euphoria, and you should add atropine in this, so that what is the side effect? Anticholinergic side effect will be there, and they have a reduced efficiency or effect of abuse. What are the contraindication? Less than 4 hours, toxic megacolon. Contraindication, if it is going to be less than 4 years, or when there is a toxic megacolon, you should not use this. You cannot use this. Then file your diphenoxylate. Okay, now moving on towards the next one, that is going to be your drugs for IBD, inflammatory bowel disease. This will be the last part of your GIT, maybe the last part of your pharmacology itself, because we have completed all the drugs. Now we have the last part in the pharmacology. So what are going to be the drug for IBD? Can you tell me the drugs for IBD? You have your ulcerative colitis and Crohn's disease. In ulcerative colitis, only in colon there is going to be a problem. Okay, mainly always in the rectum. Okay, whereas your Crohn's disease, it is going to be mouth to anus, but there will be a skip lesions, cobblestone appearance. All this we discussed when we are discussing in pathology, isn't it? The first one is 5-amino-salicylic acid. Remember, 5-amino-salicylic acid, you are going to have your mesalamine or 5-ASA. Can you tell me in which drug you are going to? We have already seen this. ASA, amino salicylic acid as a component? Can you tell me what is a drug where we add amino salicylic acid as a component? In which drug we add amino salicylic acid as a component? Can you just recall and tell me, guys? Someone, anyone here, do you remember? In one drug, we have this 5-ASA as going to 5-ASA as a component. You have your salicylic as 5-amino salicylate as a component. Can you tell me in which drug? I'll give you a clue also. In your disease modifying anti-rheumatoid drugs, DMARD drug. Do you know, remember? Yes, it is going to be a sulfasalazine. Sulfasalazine is going to have two combination. One is going to be a 5-ASA, number one, and number two, what we had something called as sulfapyridine. Do you remember? Sulfapyridine. Among this, sulfapyridine is going to be used for rheumatoid arthritis, whereas 5-ASA is used as a drug of choice in case of inflammatory bowel disease, especially in your ulcerative colitis. Now coming towards this as a local anti-inflammatory action in the colon, reduces prostaglandin, leukotrienes and TNF-alpha. Orally, it is going to be absorbed from the small intestine. You have two ways to deliver 5-ASA to your colon. One is going to be as a azo compound. So 5-ASA along with sulfapyridine, that is called as sulfasalazine. Or you can deliver 5-ASA with another 5-ASA compound itself, that is called as olsalazine. Whereas 5-ASA, when you're going to give along with beta-alanine, it's called as balsalazine. Olsalazine is having a less side effect compared to all the other drugs. This beta-alanine in your balsalazine, it is going to act as a transport material. It is going to decrease the absorption in your small intestine. Thus, what happens is it is going to provide more time for the local action in the colon. Okay, now coming to the oral form of 5-ASA, that is going to be mesalazine. Okay, mesalamine. So you have mesalamine. So you have a drug called as mesalamine. It is going to be the oral form of your 5-ASA. 5-ASA is going to be coated with polymer. What is going to be the drug of choice? Remember, the drug of choice is maintenance in the ulcerative colitis. Drug of choice, maintenance in the ulcerative colitis. Next, your corticosteroid. It's an anti-inflammatory drug. Oral drug, you have your prednisolone and budesonide. They are going to be the drug of choice, acute attack or exacerbation. IV, you can give methylprednisolone. Now coming to the immunosuppression, azothioprine, 6-mercaptopurine, methotrexate, and cyclosporine. What is going to be? These are the drugs we are going to give in case of IBD. So what are the two ways you're going to deliver your 5-ASA, that is going to be a 5-amino salicylic acid? Either you can give it as azo compound or you can give it as a oral format. You have to take a corticosteroid and immunosuppressants. How you are going to maintain the treatment in the Crohn's disease? See, maintenance of treatment of Crohn's disease, you are going to give immunosuppressants than the ulcerative colitis. Fourth one is going to be your MAB. What is MAB? Monoclonal antibody. So what are the monoclonal antibody you are going to give in this patient? Anti-TNF-alpha, infliximab, adalimumab, golimumab. Infliximab, adalimumab, golimumab. So these are the anti-TNF-alpha drugs. And your ustekinumab. Ustekinumab is going to be interleukin 12 and interleukin 13 inhibitor. Then you have anti-integrin antibody. They are anti-adhesive therapy. They are going to do a anti-adhesive therapy. Now let's see what are going to be the VCAM inhibitor. So that is going to be a natalizumab and vedolizumab. So both are going to be acting by inhibiting the alpha-4 beta-1 integrin. So alpha-4 beta-1 integrin, it is going to lead to use is going to be in the inflammatory bowel disease and multiple sclerosis. Inflammatory bowel disease and multiple sclerosis. Then you have vedolizumab. There is going to be your alpha-4 B7 beta-7 integrin. Alpha-4 beta-1 integrin is going to be your natalizumab. How to remember it? Alpha-4 beta-1 integrin, it's going to be a natalizumab. It's going to be natalizumab, and vedolizumab is going to be your alpha-4 beta-7 integrin. They are used in the inflammatory bowel disease. What is your natalizumab side effect? It leads to progressive multifocal leukoencephalopathy. And this is going to be, I already told about this, John Cunningham virus. So this John Cunningham virus, what happens? It is going to form an inclusion body in the pro-erythroblastic leukemia. Okay, in your pro-myelocytic leukemia, it is going to form a So that is one problem which leads to a progressive multifocal leukoencephalopathy, and you have to screen for anti-JC antibody before administering natalizumab. So with this, we are actually completed all your pharmacology topics, all pharmacology topics. So only thing with left is going to be a ANS, an autonomic nervous system. What I will do is I have already uploaded the autonomic nervous system in the YouTube. I'll send the link also in the group. And till today, whatever we discussed, I'll compile everything. Already part 1 antimicrobial is over, and tonight I will be like uploading whatever we discussed yesterday. So whatever you discussed yesterday till 11 o'clock, I'll just upload that. And tomorrow I will upload all the topics that are taken today, so that complete complete pharmacology is covered in the YouTube. So you can watch anytime. If you have any doubt at any point of time, you can actually come and you can actually message me. I'll be very happy to solve those. And what we will also do is we are also going to have a T&D discussion. So I have already uploaded almost 120 to 130 questions, not 120, more than that, around 170 questions. MCQs I have just sent in the group. So what you're going to do is you're going to solve all the 170 MCQs, and by tomorrow what I will do is I'll try to cover it as a separate video. All 170 MCQs we will try to discuss around 4 to 5 hours. We will sit and discuss at a one stretch all that MCQs. If you're going to cover it, that is going to be more than enough for any exam, not just your theory exam or not just your Viva, but every exam. All the topics are covered in this 2 days. Okay. If you have any more doubts, you can put in my WhatsApp. I'll be always open. You can just message in 8667719564. This is my number. I'm Dr. Raghu, and you can share any doubts you have. So I'll be happy to explain. So do you have any doubts till now, Afif and everyone? So I think Afif is watching from the first day itself. Do you have any doubts from yesterday? If you have any doubt, you can just post me. No, right? Okay. So any doubts, you can post me anytime. With this, we are completing the pharmacology. I'm just signing off. I'll just come back with the new subject. Already pathology is over. So only general pathology is left with. Pharmacology also over. We will try to cover the microbiology in the upcoming weeks. Thank you.